Hi friends, RS please contact the officials of the Cerebellum. You'll get to know the what classes and what are the packages and what other information that is required. You'll get that there. So please let me know if the audio video is clear so that we can proceed. Today we are going to talk about the volumes and just a recap, and then we are going to start with the volumes, capacities, and how to measure different types of volumes. Okay, and in the end we can discuss a bit about the VQ ratio. And again, I have lots of questions today because respiratory is more of calculative based and physics based kind of a system, and that's why most of the people do not like it. But it's very interesting if you like physics, a bit of physics, right? So good evening, Rahul. So let's start with the class. I hope I'm audible and visible properly. Right. So yesterday what we talked about this thing is that there are, just give me a minute. All right. So yesterday we talked about the visceral pleura and parietal pleura. We talked about the space also. So suppose inside what we have is the lungs, right? Over here we are having lungs, and there are two layers which are present, or coverings which are present. That is visceral pleura attached to the lungs and the parietal pleura attached to the chest wall. Okay, yesterday we talked about that. In between we do have spaces. Then we talked about the muscles, right? Yesterday someone asked me in the comments that other muscles. Yes, other abdominal muscle other than the rectus muscle, that also helps. Okay, so it's not that only rectus is going to help. All other muscles, like you can see over here in the diagram, that rectus abdominis is going to help us, but other than that, the external oblique, internal oblique, and transverse abdominis, all of them are going to help us in the forceful expiration. Right, so you can see over here quiet and active breathing. In the Genong, they have just mentioned the muscles that are used for the respiration and not for the quiet and active breathing or quiet and active expiration, right? So that's why I have chosen this diagram. It is pretty similar to that of the diagram which is given in the Genong. It's just that they haven't mentioned it in a separate way. Okay, so over here in this diagram, the expiration and inspiration mentioned separately. Quiet breathing, important, that is going to be passive in the case of expiration, active in the case of inspiration. We have discussed that all. Let's move on to the applied aspect. I have seen UP University and one of the Maharashtra University and South University, Hyderabad University, once asked about the pranayama. Now they have asked only two question on for the 2 marks, question for 2 marks, that is, what is the effect of pranayama in the respiration. So understand, pranayama is nothing but controlled breathing. And what is the effect? See, the students will write whatever they feel like, but over here you have to talk in terms of the scientific or medical terminologies. Okay, so we have discussed about the surfactant, a bit of surfactant, right? We are going to go in the detail of it, but then understand, they have asked particularly on the respiratory volumes. Then you have to talk about this, that pranayama is nothing but controlled breathing, and that too we are going to do deep breathing in this, right? And during pranayama what happens is, it is shown that these are all hypothesized facts, right? That it increases the surfactant synthesis and thorough spreading. So it is proved that the surfactant, as soon as you deep breathe, or you do the pranayama, or you do the deep breathing or control breathing in that thing, it is proved that the spreading of this surfactant will be thorough. So they are thoroughly spread everywhere, and because of that, what is going to happen? Definitely the surface tension will be reduced. Now, some also say that, some of the studies also say that they increase the synthesis of surfactant. but yet it is not proven properly. Okay, the second thing that is going to happen is that the magnitude of muscle contraction, which are the two muscle. If I have to talk mainly about the inspiratory muscle, that is going to be the diaphragm. That is going to be the diaphragm and intercostal muscles. It is going to increase, and because of that, if the magnitude of these muscles are going to increase, the strength is also going to increase over the period of time, and that's why it helps us in the better breathing control, right? So this is the thing over here. See, NEET Medico, this is the last class of physiology for this month. The next month schedule is yet not made, because now you're going to have the this other classes, not the physiology but biochemistry and anatomy. So we might be having one session in which I will be covering most important question and how to write the paper, rather than taking one by one all the topics. Okay, so whatever question I found out, this is just to take up the thing to the next level, and you should have the idea of the basic concept. Okay, so definitely we will be planning, you'll get the exact answer over there next month, because I do have insufficient information right now. Okay, so I do not want to comment anything on it. Let's move on to the physiological causes of less expansion. That has also been a question asked in the university exam. What are the physiological causes? Can you tell me the answer of this question? Good evening, NEET Medico. So what are the physiological causes of less expansion? Pathological causes, diseases, there are many diseases that you can name me. Okay, but what about the physiological causes? Understand, if the abdomen is extended or it is expanded already, then you do have less space for the diaphragm to contract, and that means there will be less expansion of the lung itself or thoracic cavity. Now what can be the reason? First is the obesity, right? Then pregnancy. We haven't considered the obesity as disease per se, so that's why I'm talking in the physiology itself, right? Or ascitic leg condition, that is going to be pathological. Okay, and less expansion can be there because of many diseases, but pregnancy and obesity plus the tight clothings around the abdomen and chest area, that can also reduce the expansion of the chest, and these can be the physiological causes that we can overcome. So whenever you are writing about clinical applied, what you have to write is physiological and pathological. So tell the physiological causes first and then move on to the pathological ones. Okay, push harder than yesterday if you want a different tomorrow. Okay, that's what we are going to do. We are going to go in the depth of it, right? So basic concepts are very important, and that's why we are going to go in the detail of what we discussed yesterday. Okay, and that too on the basis of what we discussed yesterday. Now by this graph, what you are or what you conclude in by this graph, which you have to draw in your exams. So if they ask about the airway or airway resistance, you have to write this graph. We discussed yesterday about the airway resistance also. In that I have told you medium size airway versus the small size airways, because the larger size airway, they do have cartilages, so they do not collapse and they don't give much of the resistance. But what about the medium size and small size airways? They have different generations, and they give a different amount of resistance altogether. And we have discussed yesterday that the cross-sectional area of small airways, it is much more as compared to the medium size airways, and that's why the resistance comparatively is going to be decreasing in the small size airways, right? So what you can see over here in this graph, or depict, or you can make a conclusion out of this graph, just tell me. I just wanted to ask one simple question that is going to be your hint, that is maximum airway resistance is seen in. Maximum airway resistance is seen in. Anonymous, the lecture has just started. Just give me the answer of this. Answer do bacho. What is the answer? what are you looking or what are you seeing in the graph is that segmental bronchi, they are going to have the maximum resistance. So what you can see over here is the medium size airway, which are going to be the conducting ones majorly, right? And the respiratory airway, as you go deeper into it, what is going to happen? They are going to divide and they are going to have more cross-sectional area, and that's why there is going to be less resistance. So what you can depict by this graph, simple, even if you do not remember at the time of exam, what you can draw is, you can draw just the airway generation, and as soon as you go towards the deeper into the airway generation or more number airway generation, what is going to happen? Your resistance drastically falls, right, in the conducting airway, and as soon as you go towards the respiratory airway, they are going to be decreasing drastically. Okay, so it is going to take, if you know this graph, it is going to take only 5 to 10 seconds definitely, but that is going to give you more marks. Okay, coming to the airway resistance versus lung volume, right? So what you can depict from this graph now, see over here on the x-axis, first of all we have drawn the volume, and on the y-axis again the airway resistance. Now just the smaller change over there, that if they ask about the volume and resistance, I'm going to draw this graph. If they ask about the resistance and airway generation in the Weber's classification, after that you just can draw this graph which we have seen already. Okay, and if they ask about the volume and resistance, you can draw this graph. You just have to change the x-axis, y-axis is going to be the airway resistance itself. Now see over here, as you increase the volume, what is going to happen? The airways or your alveoli, they are going to expand, and as soon as they expand, what is going to happen to the resistance? Remember, the alveoli are expanding, the airways are also expanding because they are present, mainly the intrathoracic airways, they are present in the inside the thorax. So that's why whatever negative pleural pressure was developed, and because of which the transpulmonary pressure has been increased, right, and that is going to expand the airways also. If the intraluminal space has been increased inside the airway, what is going to happen to the resistance? Resistance is definitely going to fall, isn't it? So that's why over here, as soon as the lung volume start to increase, that means the pressure is falling much and much more, right, and that means the intraluminal space is increasing, and that means the airway resistance is also decreasing. You can see over here, lesser the volume, lung volume, that is going to increase the airway resistance, and higher the lung volume, it is going to reduce the airway resistance. Why? Because there is a negative pressure which is not only acting on the alveoli, but also it is going to act on the airway too, right? So I have found this very nice meme that, wow, you seem stressed today. What is the tension? So that is nothing but the surface tension. Why? Because he's lying in the contact of air and water, and exactly on the transition he is lying. So definitely he'll be tensed. Why? Because his surface tension is acting. So funny, but yeah. And yesterday we have discussed this also, that can you identify which cells are these? These are going to be your simple squamous epithelium. Then what is this? These are nothing but the cytoplasmic extension of these. Cytoplasmic extension, this is nothing but the type 1 alveolar cell. Type 1 alveolar cell, and what is this? This is the type 2 pneumocyte or alveolar cell. What we have discussed about this, that these are going to cover the 95% of the surface area, and these are the cuboidal cells which are going to cover 5% of the area. Okay, let's move on. What I wanted to tell you about this is that they do have some bodies which are known as, these are X bodies which are going to release the surfactant, which also act as the storehouse of surfactant. So who is the storehouse of surfactant? Please let me know in the comments. Who is the storehouse of surfactant? Tell me. Then one more diagram I wanted to show you. Yes, many diagrams are coming and much more information is going to be there in today's lecture. So see over here, what you can see that I have introduced a catheter, but it is not going into the bronchi or respiratory system. Where is it then? It is in the esophagus. This is present in the esophagus. Now, why I have introduced the balloon catheter into the esophagus? Now understand, it is proven by the research that whatever pressure is present inside the esophagus, we are going to call it as intraesophageal pressure. It is proven that it is almost equal to the intrapleural pressure, and that's why whenever I'm going to insert the catheter over there and there is a pressure transducer which is going to be attached over here, which will be from outside, it will be attached to a computer which is going to give us the either graph or the digital values of that pressure. Right, so what is going to happen via introducing the catheter, balloon catheter inside the esophagus, I can get the value of the intrapleural pressure. Okay, so it is going to be the same pressure as it is present in the pleura, right? Alright, so let's move on to the next thing. That remember, in one university exam in the Delhi also, in 2019 paper, they have asked about the relationship between the surface tension and the TPP, that is the transpulmonary pressure. Transpulmonary pressure and surface tension. Can you tell me on the basis of yesterday's class, what do you mean by transpulmonary pressure? Trans means across, right? And across what? I'm going to check across the lungs what is the pressure. And across the lung, I told you how to calculate the trans pressures. You have to see the adjacent layers and in minus out. That are the only two steps present over here. So inside, just inside the lung, we do have alveoli. And how I'm going to calculate it? So suppose this is the lung and this is going to be the parietal pleura, isn't it? And just inside it is going to be the intra-alveolar pressure, and just adjacent to it is going to be intrapleural pressure. And in minus out, that means I'm going to calculate it as intra-alveolar pressure minus intrapulmonary pressure. And intra-alveolar pressure at rest, if I calculate, intra-alveolar pressure is equal to the atmosphere. That's why it is able to be at rest. Otherwise, what is going to happen? If there is any presence of gradient, either the gradient can be towards inward, then the inspiration will take place, or towards outward. That means the intraalveolar pressure is more than the atmosphere. The air is going to go out, which we do not want. At rest means there is no movement of water, and that means the pressure inside it is 0 mmHg, which is going to be equal to the atmospheric pressure. And what about the intrapleural pressure? We know that the intrapleural pressure at normal condition, also resting condition, it is minus 2.5 mmHg. So what is going to be the TPP over here? It is going to be plus 2.5 mmHg, right? So remember, more the transpulmonary pressure, that means more is the gradient or more is the difference in between these two. What do you mean by surface tension? Now understand, the relation of surface tension is, we'll see how it is. Usually it is inversely proportional to it. Why? Because see, more is the transpulmonary pressure. That means if suppose I said that this is minus 1, okay, minus 1, what is going to happen to this? It is going to be lesser, right? So if the transpulmonary pressure, if IPP is going to be more, then the this transpulmonary pressure is going to be lesser. And how they are related to the surface tension? Remember, if the TPP, if the IPP is lesser the IPP, what is going to happen? More will be the TPP, right? And because of this, what is going to happen? If more is that and the surface tension is active, and surface tension is inward force. right? And surface tension is inward force. This is the IPP is trying to pull it outside. Why? Less means more negative, right? More negative is the pressure, TPP, right? What is going to happen? Let's say TPP is more negative, right? Or more. TPP is the value which is the difference between two. So if the TPP is more, then surface tension is going to be counterbalance. Now what is going to happen? What is the relationship between two? More is the TPP, transpulmonary pressure is the one which is increased. That means there is chance or increase probability or increase chances or increase outward recoil which is going to be present, right? And if I say that the surface tension is there, that is the inward recoil, right? If the TPP overcomes the collapsing effect of the surface tension, then only the IPP is useful, or change in the IPP is going to have an effect. Otherwise, if the transpulmonary pressure is not able to overcome the pressure or the effect which is given by the surface tension, no matter how much negative it is not going to put any effect. Okay, so if it is able to overcome, if the TPP is able to overcome the collapsing effect of let's say the surface tension, the negative IPP, only then the negative IPP will have effect on the volume or expansion. For example, let's say during inspiration, the IAP becomes -1, right? So before, how much it was? IAP was 0, right? But in the intrapleural pressure, if we talk about intrapleural pressure during inspiration, it becomes -6. We know that from -2.5 it is going to go towards the -6. So that I'm talking about IPP. So TPP is equal to, at rest, let's say at rest it is TPP is equal to IAP, that is 0 minus -2.5, that is going to be +2.5. But during inspiration, this will become -1 minus -6. That is equal to, now see over here, this is going to be -1 plus 6. So that is going to be +5, isn't it? So it has been almost double. So 2x, it became 2x, and that's why it will be able to overcome the surface tension, and that is going to give us the effect. And what is the effect? There will be expansion of the alveoli, right? So 2x, so that's why it will be able to overcome the collapsing effect of the surface tension, and that's why there is going to be alveolar expansion. So they have asked you the effect in the university exam. I guess it is for 2 marks or 3 marks. I've seen this question, so you can explain that with the example also if you know the concept over here, right? Let's move on to the compliance. Can you tell me what do you mean by compliance? Same as pleural pressure. What is same as pleural pressure, Vijay? Med Psycho, good evening. Chalo, tell me what do you mean by compliance? I have told many times what do you mean by exactly. What is the meaning of compliance? Compliance meaning? Yes, please tell me. It means stretchability. It means stretchability or distensibility. Stretchability or distensibility. distension, that means how much the alveoli and the airways can expand. Okay, so that is the case over here. So stretchability or distensibility, how to calculate that? Remember that the lungs are like the balloon, right? So how to calculate it? Compliance is how much the airways, that is inside the intrathoracic airways, and that is inside the thorax, which are able to stretch or distend. So the lungs are like balloon. Balloons, they do have elastic fibers or elasticity, right? Same, the lung has the protein which is known as elastin, right? Which can stretch, but understand it has the property to recoil also. So it is the protein which contains two properties, just not only stretch but also recoil. So yes, it is going to get distended or stretched, and with that, after leaving, once the tension for the distension or stretchability is over, what is going to happen? It is going to recoil back. That means recoil means returning back to the normal position. Returning back to the normal position. So this is going to be the case in the lungs also, right? So if I have to tell you that if there is a protein which is known as elastase, what do you think it must be doing? Elastase, whenever the ACE enzyme is going to come at the end, so it is going to break down the elastin. Now, if it start to break down the elastin too much, we'll lose this property of compliance also, stretchability or distensibility. We don't want that. So, what we can do over here, stretchability or distensibility, what we can do over here is that we can put a regulator which can inhibit this also. What is that? Alpha-1 antitrypsin. Alpha-1 antitrypsin, it is going to inhibit the elastase which can break down the elastin. So if the alpha-1 antitrypsin is present inside the lung, it won't be able to make the, or elastase won't be able to act on the elastin and break down it. So it is basically preventing the elastin ka breakdown. Remember, if the deficiency of the antitrypsin, alpha-1 antitrypsin is there, what is going to happen? This alpha-1 antitrypsin won't be able to act, isn't it? So if there is a deficiency, this alpha-1 antitrypsin, if there is a deficiency of it, this won't be able to act. If it is not able to act, will the elastase inhibited? No, there is no negative regulation of it, and that's why there will be more and more breakdown of the elastin protein, and definitely we are going to lose that stretchability or distensibility, right? So that is the clinical applied aspect of this alpha-1 antitrypsin deficiency, right? So in the alpha-1 antitrypsin deficiency, no negative regulation, of elastase, and because of which there is going to be increased breakdown of elastin protein. Now what is the main function of elastin protein? Understand, if there is a negative pressure, yes, the alveoli will stretch, but the main thing of elastin protein is to come back to the normal position. So that means the recoil is the main property of elasticity. If the recoil is because of the elastin protein and there is more or excessive breakdown of elastic protein is happening, will the recoil take place properly? No. And if the recoil is not taking place properly, what is going to happen? There will be accumulation of the air, which is also known as air trapping. in the lungs which is going to be present. Air trapping inside the lung will be present over there, right? So that is the case. And can you tell me what is the name of it? Okay, neat medico, I'll do that. Somebody asked me to complete the renal physiology, start renal physiology. Let's see how it goes. Okay, don't worry, I'll do that. Deficiency causes emphysema. You're absolutely correct. This is the parenchymal disease that I was asking about, and Abdul already answered me. Very good. So yes, it is the emphysema, in which what type of chest will be seen? It is like a used up socks or used up rubber band. Normally your alveoli are like new rubber band, but if you use up the rubber band or stretch it again and again and again, it is going to lose its elasticity, and if it loses its elasticity, we all know what is going to happen is that it loses its elasticity, and definitely it is going to cause the air trapping inside the lung, right, which is not definitely good sign. Okay, and the patient will be having a type of chest which will be, yes please answer me, because of the air accumulation, which type of chest will be seen? Yes please. Till that time you give me the answer of type of chest, I'll move on to this graph. Now we have discussed yesterday that if we talk about the compliance curve, then I'm going to talk in terms of transmural pressure, and I told you trans is always the difference between the two, right? Inside minus outside. So if I take the difference between the two, what is going to be seen over here? That I told you already, that if you calculate it for the transmural pressure in the lungs, what will be the case? It is always going to be starting with the positive, right? It cannot be negative. Why? Because you know that the IAP, as it will fall, the IPP will be falling much more, right? And because of that, your answer ultimately is going to go towards the positive. And that's why if you see that any graph is just starting from the positive side, so that cannot be any other than the lungs compliance curve. Okay, so this is the only one which will start from the positive side, that is after the zero, which is going to be the compliance curve of the lung. That means it is the pressure difference across the lung, or transpulmonary pressure, right? So this is nothing but the transpulmonary pressure lung ka graph, and that's why they have mentioned as PL. This is a graph from the similar graph from the Guinea, right? And if you draw the chest wall ka compliance curve, right, or the transmural pressure across the chest wall, and you have plotted it against the change in the lung volume, it will become compliance again, right? It is the chest ka graph. Okay, and there is some graph in middle that is going to be always and always between the trans-respiratory. We have discussed that suppose this is the lung and this is the chest wall, right? So transpulmonary is going to be this one, right? So whole across the lung, that is going to be the average of these two, right? So this is the trans-respiratory pressure curve which is going to be there. Now one more thing about the compliance, that how to calculate the compliance. What is the compliance? As I told you that suppose this is the balloon and we are inflating the balloon. If I change the pressure inside the balloon, definitely let's say I put the positive pressure inside it. Okay, so if I start to inflate the balloon, that means I am putting positive pressure, right? Or there is a negative pressure because of which the air is going to move towards it. Now what is going to happen is that it will be distended to a new volume, right? So how much volume change occurred in the balloon per unit change in the pressure, that is going to be your compliance. So how the compliance is calculated? It is the per unit change in the volume after changing the pressure, right? So per unit change in the pressure, how much volume is changed and it came onto the new descending volume, and that's how you're going to calculate the compliance. There are various types of compliance, but then again we are going to check those compliance as and when we are going to move forward. Okay, so compliance is very important, because many questions are going to come on this. Now look over here, this point is very important. What is this point? This is the point where these two transmural pressures, that is the transmural pressure across the chest wall and transmural pressure across the lung, they are going to balance each other exactly. That means the forces of the chest wall and the pleura, they are going to be equal and opposite at this point. The pressures, the transmural pressures of lung and chest wall, or across the lung and chest wall, they're going to balance each other, or you can say that they are going to be equal and opposite. And whenever something is equal and opposite, we call it as some point. What is that point? That is nothing but the lung has reached, or the respiratory system has reached the equilibrium point. Right? And when this is possible? This is possible at when the lung are at FRC. So please remember, at this point, at the FRC, there will be no muscle contraction. Why? Because we are not doing forceful expiration, we are just doing normal expiration, and for the normal expiration, we do not require any contraction of muscle. We just have to relax the muscles which were contracted during the normal inspiration. So we have relaxed the muscle. Now no muscle is contracting, and that's why this volume, this FRC, is also known as relaxation volume. And the pressure which is present at this point is known as relaxation pressure, because all the muscles in the respiratory system, they are relaxing, and that's why this is known as relaxation pressure also, right? So please remember, they are going to ask you, and this is already asked in the AIMS examination, they mark the point that is X, right? And they ask what is the volume that can be present at X. The options given were tidal volume, inspiratory reserve volume, expiratory reserve volume, and FRC. Definitely the answer over here is FRC. Why? Because there is no muscle contracting, and this is very, very important that though no muscle is contracting, but the lungs are stable. Why they are stable at the FRC? Because understand, the chest wall want to recoil outward and the lungs want to recoil inward. So that outward versus inward force is exactly balancing each and other, and that's why there is going to be no movement of the air and there is no collapse of the lung at the same time. Okay, and that is why it is very, very, very important, right? So let's move on to the next point. Before that, if I tell you how to remember, because again you will be thinking that whether the transpulmonary pressure was positive or the chest wall pressure was negative, and how to draw this diagram. It's very simple, that what you can do is, so what you can do over here is that you can simply draw the diagram like this. This is going to be my 0 point. This will be one pressure, right? This will be another pressure, and in between I'm going to have something which is going to intersect between these two, right? And that is going to be the middle pressure. Now, how to remember which one of these is chest wall pressure, lung pressure, or transrespiratory pressure? See over, very simple mnemonic. C comes first and then comes the L. So the C is going to be the first one, and we know that average is going to be in the middle, right? Average won't change. So I'll just change this graph a little bit because the average will change accordingly. So the average is always going to be changing like this. Okay, so average is going to be middle, so it is going to be the transrespiratory pressures, right? And this is going to C come first, then the L comes. Okay, yeah, so you can write pulmonary, transpulmonary, or the transmural pressure across the lung. So C comes first, chest wall rather than wall, we can remember as C, that is the alphabet which comes first. Okay, so that is the case in this scenario. Let's move on. It will take only 5 to 10 seconds to write this transmural pressure on the x-axis and y-axis volume, right? Because pressure and volume are important, and that's how we are going to calculate the compliance, isn't it? Now, if you talk about this graph, it will take hardly 2 1 minute, let's say 1 minute is more than sufficient to make this graph. You're going to mark it as FRC. Over here there will be transmural pressure, over there will be volume, right? So this is going to be the compliance curve, only few seconds or maximum minute, right, to label it properly and write it, but it is going to give you definitely good marks. Okay, now if I draw this transpulmonary pressure, now understand this is not transmural pressure, transpulmonary pressure. As I already told you that TPP is going to be positive. Why? Because negative minus negative is going to be positive, right? Minus negative is going to be positive when they combine together, and that's why this is going to be positive. And you can see that this is crossing the 0 and coming after that. C comes first, so C cannot be starting from the positive, it is going to be the negative ones. And please check what is written in the x-axis, right? It is written at the x-axis, it is written as transpulmonary pressure, which is always going to be positive. It is not intrapulmonary, it is transpulmonary pressure, right, which is going to be positive, positive and positive, right? So that's how most of the students get confused, not you specifically, the ones which are going to study the respiratory system for the first time, that how this become positive, right? So this become positive when we subtract the intrapulmonary pressure from the intraalveolar pressure. Intrapulmonary is always negative, so when you subtract any negative thing, that is going to be positive, right? Now what they have shown over here, look, if I draw the perpendicular lines over here, so suppose I'll draw two perpendicular lines. What are the two perpendicular lines? I want to check the compliance of in the each of the type, right? So what do you mean by compliance? How much volume change occur per unit change in the when we change the pressure, per unit area change in the pressure, how much volume has been changed? So see over here, suppose this is the case. Normally I'll change the color, which is going to be more visible. So just give me a minute. So suppose it was 4.5 before and then became 5.5. So 1 liter change is there per unit when we change 10 centimeters of water pressure, right? So that is the normal change. But if I show you over here, see, in this scenario what is happening is very little change, not even 500, right? Not even 500 ml change is there. And that's why in this case what you can see over here, that the delta V is very, very less. Why? Because the lung has fibrosed. So whenever they are going to talk about any restrictive lung disease, then the graph is going to be very, very low. How to differentiate between restrictive and obstructive? Simple funda over here. What is the funda? Suppose this is the lung and these are the airways. Okay, again this is the lung and this is the airway. Now understand, I have drawn two lungs over here. Suppose there is tumor in the airway in between, or there is a compression of airway. What is going to happen? The air is obstructed to go out. It is not the parenchyma which is diseased. Suppose there is a fibrosis in this part of the lung. Now this part is completely useless for the patient. Why? Because there is fibrosis, and I told you fibroblasts are the ones which do not contain much of the properties of elasticity. So what is going to happen? There will be no compliance, there will be no recoil. And if the compliance and recoil is not there, what is the use of such fibers over there or such cells over there which are not helpful in the respiration, right? So definitely this is the restrictive lung disease, right? And this is the obstructive lung disease. What is the difference? Usually in the obstructive lung disease, there is a parenchyma, that is the airways are obstructed, right? The air is not able to move out. Suppose there is an obstruction in the way. Suppose if you're going out of the hall, and what I did was, there were two doors, let's say. I closed one door and I closed the half door of the first half part also, right? I close or shut the doors very closely, okay? Only one person can go at a time. Then what is going to happen? It will take more time to empty the hall. Suppose there are 20 students ka hall, right? And to go out, we had two doors. One door I opened at the halfway through, and one door I completed closely. So suppose this was the door, like this, okay? So what is going to happen? The time taken by the students to come out of this room, I'm measuring the time, okay? So I'm measuring the time. So what is going to happen? Definitely the student will take more time, but all the students will come out. But if the doors are open completely, second scenario, if the doors are open completely, but I have tied the student to the chair, what is going to happen? Though the airways are intact, but there is no air, or the students won't be able to come outside. Why? Because I have tied them with the chair, right? I don't do such things. I'm just giving example. No need to get scared, right? Or don't do my complaint, because it's just the example that I'm giving, okay? So the students will not be able to go out. They will be attached to the chairs itself, right? And that's why this is known as the restriction which has been taken place on them, and that is nothing but the same thing happening in the restrictive and obstructive lung disease, okay? Now, if I talk about emphysema, it is the parenchymal disease again. Now we have seen, just now you guys told me that the emphysema, the problem is not in the compliance per se. It is having very high compliance or very high distensibility. But the problem is that it is going to have poor recoil. It will expand, but it is not able to come back to its normal position. So if it is not able to come back to its normal position, it will start to expand. Now what is going to happen because of this? There is going to be air trapping, and nobody told me till this point that what type of lung you are going to see in the case of the emphysema. Please remember, in the case of emphysema, what we are going to see is the barrel chest. Barrel chest, okay? Rohit Ram, definitely the physiology is important. If you do not know physiology, you cannot learn medicine or pathology. How do you expect that you do not know the alphabets and you went to learn the the literature of English or any other topic for that matter, or any other language? So this is kind of the fundamental base. If the base is strong, definitely you are going to crack the exams, any type of exam, very, very easily, right? And this is my first love. I'm not going to say anything about physiology. Yes, the physiology is important, okay? My straightforward answer. You might not agree or might be agreeing with that, but definitely it is very, very important, okay? This is someone said me that this is the mother of medicine, because without which medicine is not possible, right, to understand thoroughly. If you do not know what is happening physiologically, it is going to be very, very, very difficult to understand medicine, okay? Not even that, the pharmacology is based on this. If you know how the lungs are acting, definitely you know if this goes wrong, what is going to happen. And if you know the pathology, you can easily treat the pathology and come back to the normal physiological condition. If you don't know normal, you won't be able to get the abnormal things over here. So let's move on to the emphysema. Now see over here, if I change the 10 mmHg pressure over here also, then see the change, rather than showing it from the 10 to 20, because again it has reached very quickly to the maximum. If I see from 0 to 10, rather than looking at this, see over here, let's see 0 to 10, okay? So in the first case, in the fibrosis kind of a case, the volume change is 2.5 liters, okay? Not even 2.5, because at the 0 condition it had some volume already, okay? So you can see that the some volume is already present there, right? Because it won't be able to come out also. And what about the normal condition? At the normal condition, let's say If you extrapolate this graph over here, it can be 0, but it is never 0 because residual volume is always going to be there, right? So this is around 4.5 liters which is going to be there inside the lung. But you can see the 7.5, the value which is there in the emphysema. That means quickly, even 0 to 10 mmHg pressure, that means when you change the pressure, the volume change which is occurring, which is much more, it is going to reach up the maximum. Obviously after that it won't expand because this is the maximum expansion range possible in the alveoli. Okay, and that is how you are going to decide whether the compliance is low or high. So please remember, in the emphysema like condition, the compliance is going to be higher, right? Wherever there is air trapping, wherever there is a poor recoil, definitely in the case of emphysema, alpha-1 antitrypsin deficiency, in all these cases what is going to happen is the compliance is going to increase, right? This is the only condition. They can either give you emphysema or can give you alpha-1 antitrypsin deficiency. So please remember, these are the only conditions where the compliance is going to be higher. All parenchymal disease, they are going to have low compliance. Okay, so in the case of fibrosis, other diseases, they are going to have low compliance for sure. Okay, so this is the case and this is the compliance curve. You can draw the compliance curve in the two manner, right? So restrictive and obstructive disease, if you understand, can you give me any example of obstructive lung disease, bacho? Give me the example of restrictive lung disease. Restrictive lung disease and obstructive lung disease, give me the example. Now understand, our team has been focusing on the comments, right? And they have tracked that some of the other people are also coming who are not actually the students. So the message have been put up in the group that do not get distracted with the comments, and if you do not want to study, please leave without distracting the class. Okay, so let's move on to the restrictive lung disease. What about the restrictive lung disease? The example, one of the example is going to be our, just now that we talked about, that is a fibrosis, then tuberculosis, all the ISIS. What is cyst? That is the inflammatory condition, right? So tuberculosis, silicosis, asbestosis, all these conditions are going to come in the parenchymal restrictive lung disease. Not only that, the pulmonary edema, pneumonia, all these conditions, definitely in that case there is a restriction. Why? Because if the water is filled, the gases cannot cross the water, right? And that's why they are going to be coming into this, that is the restrictive lung disease. The obstructive lung disease is COPD, right? And the second thing is your asthma. Wherever the bronchoconstriction is going to happen, tumor is going to happen, foreign substances, if they get trapped in between the airways, then definitely it is going to be the obstructive lung disease which is going to take place over here, right? Now that is the example which we wanted to discuss. Let's move on to the types of compliance. 2-mark questions come on this that explain the type of compliance. Tell the compliance, what do you mean by compliance, define compliance, and tell its types. What are the types of compliance possible over here? There are 3 types of compliance. First is the static one, then the dynamic one, and there is something known as specific compliance. Right, I told you that if I have to give, I already discussed that mnemonic, or you can say the example in the last classes, that there are 2 students, right, Chintu and Mintu. Chintu got only, let's say, 5 marks, Mintu got 50 marks, right? I wanted to give the chocolate to the winner. Then whom should I give to? That was my question, and you guys answered as expected, right? But it's better to go with the proper proof, that is the complete information and not the half information. This is the half information, right? Suppose the Chintu got marks 5 out of 5, okay, and the Mintu got marks 50 out of 300. Definitely the Chintu got more percentage as compared to the Mintu. So I'm going to give the chocolate to the chintu, right? Don't give diplomatic answer like, ma'am, give half of chocolate to both of them, right? This is not going to happen. So it's better always to compare that with the specific FRC, and that's why the specific compliance come into play. What is the difference between static and dynamic? Static means we are going to ask the subject to hold the breath, and the breathing is interrupted at point, and as soon as he is going to stop the breathing, like I was inspiring, then I'm going to ask that inspires at some level and stop the inspiration, right? Then I'm going to measure what is the lung volume and what is the pressure inside it. Okay, then again I'm going to ask him to or her to continue the breathing, and then interrupt in between, and I'm going to take the another level of volume and the pressure, and I'm going to check the difference between two, right? And that's how the static compliance is measured. So the breathing is interrupted over here. Breathing is interrupted, and understand, we are going to measure the delta V by delta P at different points. It is not the continuous breathing. Breathing is going to be stopped in between, and then only we are going to measure this when the lungs are static, they are not moving. What about the dynamic, when there is going to be continuous breathing, and whatever continuous breathing is going on, continuous inspiration and continuous expiration will be measured, right? And this is going to be, then we are going to measure the delta V by delta P. Now it's okay if it is continuous or non-continuous. How it is going to make a difference? Understand, whenever you stop the breathing in between, what is going to happen is that the airway resistance won't come in between. So when we talk in terms of static compliance, it is going to make measure only the change the volume and change the pressure, that is the alveolar volume and change, right? So it is going to only consider the alveolar resistance which is going to come, and how much force we have to apply to overcome this alveolar resistance, because the airway resistance won't be measured over here unless and until it is the continuous process, right? So over here in this case, the alveolar gas exchange is measured plus the airway resistance. Main resistance from the alveoli, it comes from the surface tension, right, and not from the other things, that is elasticity and all of the airways specifically, and the tissues also. But in the dynamic, it is going to be very, very important that to measure the airway resistance. The simple question can be asked that which one of these is going to be having higher resistance. When you add airway resistance also, definitely it is going to be having higher resistance. That means you're going to see less volume change per unit change in pressure in the dynamic case as compared to the static ones. Remember, in the healthy person, the difference is not too much, but because of the airway resistance, it is going to be a little more in the case of static compliance as compared to the dynamic compliance. What about the, yes, it is the breath holding which we are going to ask the subject to do. Yes, definitely it is going to be helpful, because we are ultimately going to solve the MCQs also. I have a lot of MCQ. If you want, just you think that you know the concepts and you just want to prepare for the entrance exam, you can come at the end, like last 15-30 minutes, and we are going to discuss all the questions there. Okay, if you feel like you know this topic and you just want to have lack of time and you want to prepare something else, definitely you can use your method too. Then what is the specific compliance? As I told you that you should ask always the percentage, which is the complete information. So that's why we are going to check the compliance per unit change or per unit FRC, that is the functional residual capacity. If someone's functional residual capacity is more, definitely as compared to that, compliance is going to be reduced. Okay, so this is the specific compliance that I'm talking about. The per unit FRC, we are going to measure the compliance. So simply you're going to measure the compliance and you're going to divide it with the FRC, and that's how the specific compliance is measured. So as I told you, suppose this is like a balloon, this was a GIF, but since it is working in the keynote, so I am not able to show you this GIF. So what it is doing is it is blowing the balloon, and you know that if the balloon is already inflated, it's easier to keep the balloon inflated some more or even inflate it further. But if you start to inflate the completely deflated balloon, it is going to take much more energy, much more force is required to inflate that completely deflated balloon, right? So same funda we are going to apply in the case of lungs also. Lungs are nothing but the grapes, that is the alveoli with which it is made up of, right? And the alveoli, they act as the balloon. Why? Because they contain the elastin protein, right? So remember this funda, and you're going to solve many questions about the surface tension, about the compliance, and about the all the different things that we are going to discuss. Now, what are the types of tissue based on the compliance? We can say that there are various types of tissue on the basis of morphology, functional differentiation, but on the basis of compliance also we can divide the respiratory tissues. Now, we can divide that into three different parts. What are the types or subtypes of this? So first subtype is going to be the one which is going to have both the properties which are working properly. What are both the properties? First is the distensibility, which is going to be good, right? Then the recoil. There can be three possibilities only. What can be the three possibilities? That the recoil and compliance both are good, right? Second possibility is that the distensibility is good. That means it is able to stretch, but it is not able to recoil. So the recoil is poor. And the third possibility is that this is also poor and the recoil is also poor. Now understand, if you do have poor distensibility, you cannot recoil much more, right? That means expand nahi kiya, collapse kar diya. That is not going to happen in the lungs because this is not at all possible. You have to learn alphabets so as to get the degree in the literature, right? That is the basic funda. So you have to stretch it or distend it so as to recoil it. Recoil means returning back to normal position, right? If it is already at normal position, definitely it will have lesser or poorer recoil also. Okay, so what are the example of these conditions? So good distensibility, good recoil. That means both the properties are good. It is the healthy lung, isn't it? It is able to stretch properly and it is able to recoil properly also. That means during the inspiration, it is going to distend and allow the gas inside the lungs, and during the expiration, when the ITP is going to be building up towards the positive, definitely it is going to expire the air because the recoil or the elasticity is maintained properly. In the second example, it's like a proper balloon, isn't it? Or a rubber band, new rubber band. It is going to flood back again. Okay, so whenever you are going to stretch a rubber band and you leave it, as soon as the tension is released, who is creating this tension? Inspiratory muscle, isn't it? So during the inspiration, the inspiratory muscles has stretched the alveoli, right? And during the expiration, these are going to relax. As soon as they relax, slowly and steadily, the lungs or the alveoli, they are going to come back to the normal position, return back to the normal position, right? So this is like a new rubber band. What about the good and poor? So second is that you're able to stretch it, but as soon as you leave it, the alveoli won't go back to their normal position. That means they are having poor recoil or poor return. So this is like a chewing gum, right? So when this is going to happen, this happens in the cases of emphysema or alpha-1 antitrypsin deficiency. It is like what thing? It is like the chewing gum, right? So this condition is like a chewing gum. You can distend it, you can stretch as much as you want, but you cannot recoil it back. Okay, so you can distend it, but it will not be recoiled. recoil deflated balloon. Yes, you're right. The balloon should be deflated. Okay, or used up socks, chewing gum or used up socks. What happen when you use up the rubber band or use up the socks? What is going to happen? They'll come down automatically because they cannot hold on to your legs, and this is the normal phenomena which is going to happen because of the breakage of the elastic fibers that are present in between the clothes, right? And same is going to happen if your elastin proteins are breakdown in the cases of emphysema and alpha-1 antitrypsin deficiency, right? The next thing is, if both are poor, that means it is like a wooden box or the steel or the glass. Why? Because they cannot stretch or recoil, right? It is like a cloth, right? It is not elastic, it is like a cotton. So it is not elastic, it won't stretch, it won't recoil. Whatever its shape is there, it is going to maintain that shape, right? So this is like the poor thing which is going to happen, which is happening in the fibrosis like a condition, right? Any fibrous tissue you can take, cloth, wooden or glass like material which do not have much of the elasticity. So same is going to happen with the lungs in the cases of fibrosis, tuberculosis, asbestosis, all the osses, right, pulmonary edema, all these parenchymal disease. What happens is definitely the distensibility is poor. If it is not distending, it cannot come back now towards the normal, right? So this is like a fibrosis, right? Good is very easy, yeah. See, I don't have rubber band, otherwise I would have shown you that if I have a proper rubber band, if I leave it, what is going to happen is it is going to flip back. I'll check if I have the rubber band. Okay, so see over here, this is a rubber band, right? Normal rubber band. So if I stretch it, it is able to stretch up, and if I leave it, it will come back and flip, right? So this is like a good stretchability. Okay, it will stretch also and it will flip back, right? If I have the other thing, I don't have chewing gum or the poorly used socks, right? So what is going to happen in the chewing gum? If you chew the chewing gum and if you try to stretch it, it will easily stretch, but it won't recoil. Even if I leave it, it will be like that. Okay, so chewing gum will change its shape and adapt to the new shape, so it won't recoil. So that is the difference. In your lungs are like these elastic rubber bands, they can stretch, and as soon as the inspiratory muscles are relaxing, they will flip back to their normal size. So this is the difference between the good one and the poor one. So this is the healthy lung, right? So this is the first thing that you have to know, that is the new rubber band. Okay, it is like a new rubber band which is not used up yet, and it contains strong elasticity or the recoil property, good stretchability and good recoil property, right? So this is the case. So you have to remember that in the cases of emphysema, the recoil is poor, and that's why the compliance is good, but there is a good compliance. So every time what is going to happen? Every time the lung will distend, but it won't be able to recoil. Distended lung rather than, let's write distended alveoli, but they are not able to come back to normal position. And because of that, what is going to happen? Every time the person breathe in, it is going to have more and more air inside the lung. And if I started to stretch this rubber band too much every time, what is going to happen? Whatever elastic rubber band which are compensating the other ones, they are going to break down slowly and steadily. Suppose these are the elastin fibers, right? Some are already broken down, and that's why the others are adding up the force, or they are trying to compensate it, right? They will not be able to compensate after some time. Why? Because they will be also broken down, right? So suppose these are the elastic fibers which are already broken, right? Normally it should be like this. So let's draw the normal ones. Normally it should be the whole elastic fiber covering the alveoli. So it is able to, it's like a spring-like structure. You stretch the spring, it will able to recoil. But in this case, this is the emphysema case, right? And this is the normal case. This is able to recoil back as soon as your inspiratory muscles stop stretching the alveoli, okay? But due to this, there is a less amount of force which is going to be present, and that's why they will able to stretch more. And remember, if there is no let's say no coil is there, no spring is there, it is easier. As I'm going to use up this rubber band, it will become easier and easier to stretch it, right? So it is easier to stretch. That means the compliance has been increased a lot, and the compliance is increased and the recoil is poor. Definitely there will be air trapping, and because of that, what is going to happen? The antero-posterior diameter of chest is going to increase. But I'll just write increase in the antero-posterior diameter of the chest, and this is known as barrel chest. Now give me the normal value of antero-posterior diameter, AP diameter, versus lateral diameter or transverse diameter. What is AP diameter versus transverse diameter? What is the normal value of it? It is 7:5. If I measure my AP, that means anterior-posterior diameter, and transverse diameter, the transverse diameter is always more, right? I have written that opposite, that is 5:7, or you should write transverse first and then the AP, then it will be 7:5. Okay, so AP diameter is usually smaller, but in the barrel what happens, the AP also, in the cases of emphysema, the AP diameter increase. So even if you see laterally, it will look like a barrel, right? So suppose person's hands are here, right, and this is his chest. Very poor presentation, but definitely these are legs, right? So the chest will look like a barrel which is going to be present there, right? So this is the barrel shaped chest. Don't forget the diagrams because they are going to be helpful, right? So it will look like a barrel shaped. Why? Because of the increase in the antero-posterior diameter. It is looking like a watermelon, not the barrel. But anyways, let's move on towards the surface tension. Tell me, what do you mean by surface tension? The inward force which is present at the air and water interface, right? So the inward force, it is nothing but the inward force acting on the alveoli. You can write and expand your definition as elaboratively as you want. Just write the important words which are necessary, right? Inward force because of, it is because of the air-water interface which are present in between the alveoli. Air interface, right? This is the inward force, very important. It tries to collapse the alveoli. It tries to collapse the alveoli. Now, if I have to say one word for the collapse of the alveoli, this is known as atelectasis. So the collapse of alveoli is nothing but atelectasis. Okay. Now understand, not only that, if I say there is an inward force which is going to be present inside the alveoli, and suppose this is the alveoli, and I already told you that they are not going to be alone which are going to be present there, but the blood vessels, the pulmonary vessels, they will go surrounding each and every alveoli. Now understand, if the blood vessel is going from here and there is an inward force which is acting on this alveoli, definitely that sucking force or that negative pressure will be applied to this, and slowly and steadily the plasma will start leaking out because of that high inward force, what is going to happen because of that? Definitely the water will start accumulating in the interstitial fluid and in the alveoli, which is going to give rise to the next thing, that is pulmonary edema. And that's why it is very important to prevent this. Okay, so two things are very, very important. What are the two things? First thing is atelectasis, which is nothing but the collapse of the alveoli, and second thing is pulmonary edema, which is nothing but the accumulation of the plasma outside of the blood vessel, especially in the ECF, right? So accumulation of fluid either in the interstitial space, and ultimately finally if this inward force begin to increase a lot, what is going to happen? Definitely it is going to go in the alveoli also. Because of that suction pressure, the water will be pulled up. Okay, and this happens because there is a air water interface which is going to be present. So let's say this is the air water interface which was present. Okay, so it is very important to obstruct this or inhibit this. Who is going to inhibit that? I told yesterday also that there are molecules which are present on the top of it, and which are going to be the lipid molecules which can inhibit them, and these are nothing but the surfactants which are going to be secreted by the type 2 pneumocytes, right? They are going to act on this air water interface and break down this cohesive force and adhesive force present between the water molecules. Okay, so type 2 pneumocytes more than the Clara cell. Why I have written this? Because yesterday I told you that type 2 pneumocyte, they generate or synthesize the surfactant, but understand, for the stability of surfactant we require surfactant proteins, isn't it? We require surfactant proteins, and there are different 4 types of protein: SPA, SPB, SPC and SPD. What is SP? SP is nothing but the surfactant proteins. Okay, and they are produced, the stability is because of this surfactant proteins which are present there, and these are mainly produced by the Clara cells. Yes, the type 2 pneumocyte can produce it, but very less amount will be produced by the type 2 pneumocyte, but most of them will be produced by the Clara cells. And that's why if you do not have in the option the type 2 pneumocyte, go with the Clara cell, because specifically in the PGI exam, one of the PGI exam and AIMS exam, this question was asked and the Clara cells was given, which is absolutely true statement. Okay, so two things are going to happen, and they are going to reduce the air water interface. And via reducing the air water interface, definitely they are going to reduce the surface tension, right? And these are made up of mainly lipids, but yes, the proteins and polysaccharides, they are also present. The ratio is around 80-20. That means 80% of the lipids are going to be present, right? And main lipid out of it is going to be DPPC. Right, so please remember, type 2 pneumocytes which have the granules of the surfactants, and these granules will be stored in the bodies that you are going to answer me, that what are the bodies which are present. It's okay, Abhinav. I'm happy that you are taking interest and not putting up, useless comments. Chalo, let's move on towards the composition of surfactant. Just now we talked that it is the 80-20 percentage which is going to be there. 80% of it is maximally lipids, right? And 20% is going to be the protein and the carbohydrate which are going to be present there. Now understand, if I say that only 20% are the proteins and carbohydrates are around only 2 to 5%, or in some books it is written as 5 to 8% also. And rest of them are going to be protein. That means the least one are going to be carbohydrate. So which lipids are the main one over here? The phospholipids are going to be the main ones. And out of this phospholipid, remember, one factor which is one phospholipid very important, that is the dipalmitoyl phosphatidylcholine, which is also known as DPPC, or this is also known as dipalmitoyl lecithin, or simply the lecithin. In the NEET exam 2023 itself, they have asked that which of the following is the main surfactant. In the first in the first option they have given the phospholipid, that is dipalmitoyl phosphatidyl glycerol. Dipalmitoid phosphatidyl choline, instead of choline they have given ethanolamine. Remember, dipalmitoid ethanolamine is also going to be there, but it is not the main one, right? The main one is going to be DPPC, and the fourth option, the option D, was lecithin. So please remember, it is the very tricky question that they are going to put up. They are going to just write dipalmitoid phosphatidyl, but if you do not read the complete option, definitely you are going to mark it wrong. So please pay focus on each and every option. With that, we do have phosphatidyl or phosphoglycerol also, right? Other lipids are also there, right? Other phospholipids, around 10% other phospholipids, and some neutral lipids are also there, right? So all these things are going to be present with the cholesterol also, right? Little amount of cholesterol is also present. Now what about the proteins? In the protein you have to remember just AAA. What is AAA? First is the IgA is going to be present. Immunoglobulins, please remember, they are also proteins which are going to be present in the surfactant production, right? So I told you this is kind of a mucus which is going to be having these IgAs more, but again in the surfactant also the IgAs are present, so that if any bacteria comes and attached to the layer of the alveoli, we can have the fighting battle ready over there. Now there is another protein which is apoproteins, which are also there, and there are another thing, that is the IgA, apoprotein, and the alpha-1 antitrypsin, right? So alpha is also start with the A. So please remember that these three things are going to be present. Carbohydrates are nothing but the polysaccharides, which are very, very less. No need to discuss that. All the polysaccharides, they are almost 2 to 8%. You can write that range if you want. Okay. Let's move on. What is important? The most common out of all is DPPC or lecithin. Please remember that DPPC or lecithin, this is going to be the most common one. Usually this is going to be asked in all the entrance examinations also, or your MCQs in the university exam. Coming to the production starts at, what do you think? In the fetus the production is started, or when the person is born the production is going to start? Tell me when the production is going to start. Yes, Varun, you're absolutely correct. It's the lamellar body which are going to store them. Okay. You can see in the diagram also, yesterday also we have discussed this diagram, that first of all what happens is from the blood, remember I told you blood vessels are crossing these alveoli over here, right? So what is going to happen is that from this blood vessels, these cells are going to grab the substrate. Okay, the substrate is going to go in the cell, and as soon as it goes in the cell, this will be grabbed by the our cells, and the nucleus is going to put up the genetic code. It will activate the transcription, translation, right? As soon as this translation is activated via the mRNA, new proteins will be synthesized, right? The Golgi apparatus and endoplasmic reticulum, they are going to form new proteins and they are going to process it. As soon as the Golgi apparatus is going to process it, as it enters, it is known as cis end of the Golgi, right? And it is going to get stored in the ciliary bodies, right? And that is going to go in the lamellar bodies in the form of tubular myelin. This TM is known as tubular myelin. That means the folds are formed of that surfactant. As soon as the surfactant is required, these folds will be unfolded, this myelin will be unfolded, and they will start floating on the surface of this water, and that's how the surface tension will be reduced. Okay, So what do you think when this is produced, bachcho? In the fetal life itself. Very good, very good. So it is around 20 to 24 weeks. This will production will start. It's not that we are going to see or will able to detect it, but the production is started at 20 to 24 weeks, and it appears in the amniotic fluid very late, that is around 28 to 32 weeks. And this is of intrauterine life that I'm talking about. Intrauterine life, that is IUL, intrauterine life. In that the surfactants, they will be formed, and definitely we want the baby to be ready to breathe, and that's why they are going to come up before the birth towards the alveoli. Yes, viability and survivability, very good, right? So that's true. It is secreted by the organelles, which is known as the lamellar body, or inclusion bodies are there, which are known as lamellar bodies. Okay, in the form of, if you want, you can write over there that in the form of tubular lining, these are going to be present. In the form of tubular myelin, this is going to be present. Okay, and they are going to get spread out thoroughly. Then they will be spread thoroughly. Okay. They will be spread thoroughly. Okay, on the layer of water. Okay, so this is very important fact over here, that to remember that the inclusion bodies are present, or the lamellar bodies, they are present in the type 2 pneumocyte. What is the applied aspect of it? Can you tell me what is the applied aspect of it? Yes, please tell me what is the applied aspect. What you can see in these two things, first thing is shown and the second diagram is also shown. Tell me what is the difference between these two. What is the difference between these two? Yes, lipid forming machinery, very good. So over here you can see that properly inflated alveoli, and over here atelectasis is seen, that is nothing but the collapsed alveoli. If your surfactants are less, surface tension will be more, and if the surface tension is more, definitely the baby won't be able to breathe, right? And because if he's not able to breathe after getting birth, there is no one to supply the oxygen. That means mothers, we are going to cut the umbilical cord, mother's blood will not be supplied to the baby anymore when we cut the umbilical cord, and definitely baby has to take up the breathe so as to get the oxygen from the environment on its own. But his alveoli are not able to do that. Why? Because the surface tension is going to be reduced over there, right? What is the disease that I'm talking about over here, Roy? What is the disease that you can see? Yes, Prabhakaran, prevent the collapse. So that is right. So it prevents the collapse, prevent the this atelectasis. But what is the disease that is going to happen if the surfactants are lesser? If the surface tension is less, it is going to be easier to expand for the alveoli. It is easier that the expansion will be easier. Okay, surface tension make it more difficult, which is the against is the inward force, expansion is the outward force, right? So if the surface tension is lesser, it's easier to expand, and the work done will be reduced. The total work done that the baby has to do, it is going to reduce. That means the force the baby has to produce so as to expand the alveoli, that is going to be lesser as compared to the other condition. If the surfactant is not proper, then there is a disease which is known as RDS or ARDS. Yes, you guys are right, Varun, you are absolutely correct. So this is known as RDS. Mainly because of the premature born babies, we can see that, or there is a deficiency. There are various diseases such as the diabetics. In the diabetic mother, we can have the RDS because The insulin also promotes or facilitate, or it has the stimulatory effect on the surfactant production. If the mother's insulin is not proper, definitely what is going to happen is the baby is going to take all the nutrition from the mother. The insulin is going to cross the placenta, go and reach to the baby, and that is going to have the effect on the baby's growth as well as the surfactant production. But if it is less or the thyroid is less, right, then definitely the baby is going to have a lot of problems. Okay, now RDS is respiratory distress syndrome. So RDS is nothing but the respiratory distress syndrome, and this is also called as HMD, that is hyaline membrane disease. Hyaline membrane disease. Yes, neonatal respiratory distress syndrome, or this is happening just after the birth. There is no much of the time left for the baby, right? So this is also known as ARDS or HMD. ARDS is acute respiratory distress syndrome. In a short amount of time, this will be exaggerated. Why? Because baby suddenly cannot produce the surfactant, right? Beforehand, because of the mother's blood, he was getting the oxygen, but now he has to breathe on his own. There is no proper sufficient duration in which he can produce more surfactants, right? So this is going to be acute condition. And if I talk about, before going to the Laplace law, if I talk about, let's say, right, so if I again talk about the surface tension or surfactant, who is going to increase the surfactant production? The surfactant production can be increased by, as you asked me for the treatment, the three things help in the surfactant production. Please remember the mnemonic SIT. What is SIT? S for steroids, insulin, and thyroid hormone. So these are the hormones. There are many things, but the main is the hormonal things which are helping us, right? That is steroid, insulin, and thyroid hormone. Steroid, mainly the glucocorticoids. They are going to enhance or they are going to stimulate the surfactant production. And if the baby is having less surfactant, or the baby is born prematurely, right, when these are going to decrease, the surfactants are decreased in the cases of premature born babies. If the baby is born, because for the complete maturation we require at least 38 weeks. If the baby is born before 38 weeks, definitely the surfactant won't be produced or completely whatever levels, adequate levels are required, that won't be there in the alveoli. If they are not there, definitely the baby has to put more work to breathe, right? Or the mother is diabetic. There is a problem in the insulin production which is going to affect the baby's surfactant production again, right? So definitely these conditions can lead to the ARDS or your hyaline membrane disease. You can see that the collapsed alveoli, even if you try to, totally collapsed balloon is there and you have to inflate the balloon, it is going to take much effort. But if the balloon is somewhat already expanded and now you try to expand it more, inflate it more, definitely it is going to be a little easier as compared to the first scenario. So same is going to happen with the alveoli also. If the alveoli, they are distended properly, then it is going to take less work, and that's why we do have residual volume in our alveoli, so as not let these alveoli collapse completely. Otherwise most of our energy will go in breathing itself, right? Coming to the Laplace law, we have discussed a lot about the Laplace law in the CBS system itself. Just tell me what is the law which is going to be applicable over here. If I tell you that the alveoli, they are spherical shaped, they are spherical shaped, spherical in nature, almost spherical in nature, That means both the radii are going to be similar over here, and that's why we apply the formula over here that if I want to know the P, that is the distending pressure, it will become 2T by R. 2T by R, isn't it? Thank you, Teju. Thank you so much. So P is what? P is distending pressure, the pressure which is required for the distension of the alveoli. So it is nothing but the distending pressure. Distending pressure, right? And what about the T? T is the tension, wall tension. What do you mean by wall tension? This is the wall tension. If I give a cut over here, with what tension, with what force, this wall is going to rupture or it is going to get separated. So suppose if there is a blood vessel, let's say this is the blood vessel, right? And I give a cut. What is going to happen? As soon as I cut it, this wall will try to go in an opposite direction. This is the wall tension which is going to be generated due to its radius and due to its tension which is present in the wall. Okay, so this is known as wall tension, and for the distension, so as that the alveoli won't collapse, we require the pressure, and R is nothing but the radius over here. Now we do not want our alveoli to collapse, but we are still changing its radius while inspiring and expiring. Because of the Laplace law, thankfully our alveoli won't collapse, okay, and they are interdependent. That is the one more thing which is going to maintain the stability. So Laplace law is applicable for the stability of, please remember, it's very important for the stability of alveoli. And the other thing is that these alveoli are interdependent. So what happened in one alveoli, if the radius start to decrease, the other will be having more expansion, so as it will push the air into the other alveoli and it won't allow it to collapse. So it is known as interdependence. They are interdependent. Why? Because they are interlinked between each other. But since we are talking about the children, in the neonates, the linkage of these alveoli are poor, and that's why the interdependency is not well developed. And that's why the Laplace law is the way to prevent the alveolar collapse over here. Okay, what is going to happen in this case? That whenever you are inspiring, what is going to happen? The radius will increase. As the radius will increase, the pressure will start, distending pressure will start to collapse. But remember, as the radius is increasing, proportionate increment in the tension will also be seen. And if both are increasing proportionately, the pressure is going to be maintained to its normal value, because if the radius is increasing, proportionally the tension is increasing, both the numerator and denominator is going to increase and the ratio is going to remain the same. So that's why, thankfully, that the alveoli are going to be stable, they won't collapse, right? Thanks to the Laplace law that we do have stability in our alveoli. Tell me how the work of breathing is calculated. Question comes on this, short question. Now remember, there are two things which are important for this, that major and minor. There are opposing forces on which the work done during the breathing is dependent. I'm going to just give you the major chart based format over here. You can just elaborate that if it comes in the exam, right? Completely separated sacs, but they are connected with the alveolar ducts, right? So they are connected with the alveolar ducts, okay? You're right that they are separated. Alveoli are not interconnected, they are separated, but the alveolar ducts are interconnected, okay? Chalo, there are two forces. What is the major force over here? Major force is the inward driven force against which we have to work, right? And the minor one is the tissue elasticity. Remember, when I'm going to say the inward force, that is going to be the major one. That means 2/3 of my work done is because of this. Okay, to act against this or to produce a force so that I can manage or I can balance the inward force. And almost 1/3, or to be precise 35%, is because of this. Okay, and remember, inward force, the maximum of the inward force is because to we have to work against the surface tension so as to balance the surface tension. We can write it over here 65% around, right? Please remember, the surface tension alone contributes to more than 40%. Okay, and there is some inward force which is going to be present with the surface tension because of the resistance which is going to be there. Rather than writing elasticity, we can write the elasticity over here, and we can write the resistance over here. Resistance is going to be inbuilt there, and then it will be divided into two, and over here there will be tissue elasticity, parenchymal elasticity or tissue elasticity, which is going to contribute lesser because it is also producing the inward force. What about the resistance? Two types of resistance are there. First is the airway resistance and the tissue resistance. Airway resistance and tissue resistance. What is their contribution? Remember, out of this 35%, the 28% will be given to this airway resistance itself. So in the resistance, the maximum contribution is because of this airway resistance, right? And the rest of it is going to go towards the tissue resistance. So that's how you can make the chart of it, and you can just elaborate all these points, right? Who is going to be the cause against which we have to work maximally? This is going to be the surface tension, and thanks to the surfactant, our work done is a little bit reduced and we can work against that. Okay, so surface tension is going to be the main cause over here, right? So the main one against which we have to produce or we have to work, right? If the surfactants are not there, again the surface tension will be much more, even more than 60%. So we have to again work more and more to overcome that resistance. Now what is this? Can anybody tell me what is this? I'm not asking about the graph. I'm going to explain the graph. Just whenever the graph comes, first thing that you have to see the x and y axis, and the second thing, don't get scared by the graphs. Okay, even if it comes in the exam, especially in the MCQs, the students are scared of the graphs. Don't get scared of the graph. First of all, that is the first thing. Second thing, look at the x and y axis. Most of the information is going to get by this x and y axis. Okay, so pressure and volume, we have talked about the pressure and volume just now, just few time before. So what is the ratio of the volume change per unit pressure change? When you change the pressure, the volume is going to change, right? Some time back we have talked about it. What is that called as? This is known as compliance, right? So see over here, there is a difference. When the air is moving in and out of the lung, there is a difference which is present during inflation and during deflation. And when you fill the lungs with the saline, definitely we are not going to do that in the human beings. If the human are dead, then we are going to do that, or we do that in the animal's lung. Okay, so we are going to make the lung model, and in that we are going to do these all experiment. We do not want to do that. Pressure volume curve, yes, you can say this is the pressure volume curve, but again this is the compliance which is showing over here, right? That is what is the difference in the compliance during inspiration and expiration. Yes, Varun, Roy, you guys are right. Now see over here, if I say that during the, you can see, if I say the difference between these two, right, and you can say during the deflation the difference, which is much more as compared to the inspiration, isn't it? That means the compliance is higher during the expiration. Why is it so? Please remember that First of all, this is known as hysteresis loop. So whenever you fill the air with the lung, fill the lungs with the air, fill the lung with the air, what is going to happen? There will be air-water interface, and because of that you have to act against the surface tension. It is easier to keep the alveoli expanded when they are already expanded, but at the starting of inspiration, remember, they will be at the residual volume. Yes, some volume will be there, but understand it is almost deflated, right? So it is the least inflated part which is going to take much more work done to inflate it, right? And that's why when we talk about the air-water interface will be there, surface tension will be there, and at the beginning of the inspiration, what is going to happen? That it will take much more amount of work done to inflate the alveoli as compared to the during expiration, because during expiration we are coming back. But during expiration, what is going to happen? It is much more easier to keep the already expanded alveoli. The alveoli are expanded during the inspiration. That's why we are doing the expiration, isn't it? Without the inspiration, expiration is not possible, right? That is the first funda you should clear. Don't ask the question that how, ma'am, this is already expanded, because we have inspired already, right? So it is much more easier to keep the inflated balloon in the inflated condition rather than inflating it from the deflating condition. Okay, so same is going to happen in the alveoli, that when you start to inspire, you're going to start from the zero, right? That means the residual volume, right? And when you are going to inspire completely, as you are starting to deflate more and more, it is going to suddenly, you are going to have more volume change as compared to the initial condition, right? Why? Because again, the surface tension against which you have to act is going to be reducing by the radius is increasing in that case, right? It is much easier to expand the somewhat inflated balloon, right? Same is going to happen with the alveoli. At the beginning of the expiration, what is going to happen? See over here, at the beginning of the expiration, now your lungs or alveoli, they are already expanded, right? It is much more easier to keep the alveoli expanded in this condition. So that's why when I am going to reduce the pressure, the volume is going to reduce, because I do not have to work against the surface tension. Rather, during expiration, the surface tension is helping me. During inspiration, what is happening? Look over here. For inspiration, I have to work against the surface tension. Surface tension is inward force, and for the inspiration, I have to put the outward force, right? I have to stretch the alveoli during the inspiration. But during the expiration, what is happening is, it is actually the surface tension is helping me out, because this is also inward force. During expiration, we have to move the air out. So that's why because of the positive intrathoracic pressure, we are again trying to compress the alveoli. So both are acting in the same direction, and if they are acting in the same direction, definitely it requires less of the work done. In the less pressure change, more volume change will be seen, right? And that is nothing but the compliance is much more in case of the during the expiration as compared to the inspiration. And this difference in the compliance is known as hysteresis. So this is known as hysteresis, and this is because of the different changes are occurring during the inspiration and expiration. First is that it is much more difficult to expand the deflated alveoli, or almost the alveoli which are almost collapsed, that is at the residual volume. It's very difficult because we have to act against the surface tension, right? And that's why per unit pressure change, the volume change will be little. And if you talk about the expiration, in that the surface tension is acting along it. So that's why it is actually helping during the expiration, and that's why the quick and sudden changes are going to be there with less amount of use of energy. Okay, but it is the surface tension. But what if I say that I fill the lung with the saline? Now what is going to happen? Tell me. If I fill the air, the lungs with the saline, what is going to happen? Definitely, there will be no air-water interface. There is no air-water interface. If there is no air-water interface, that means there is no surface tension. If there is no surface tension, there will be almost negligible or no hysteresis. Almost no or negligible hysteresis, and that's why if you see the compliance during the inspiration and during the expiration, it's almost overlapping. Right? So that's why it's very, very important to clear your basics. If you know that this is because of the air-water interface and there is no air now, I'm filling the lung or I'm filling the alveoli with the saline. I'm going to remove all the air and put the saline into it. If I put the saline, there is no air-water interface. There is no air-water interface, that means there is no surface tension. There is no inward force against which I have to act during inspiration, or there is no surface tension which is acting along the expiration. Whatever is there, it is the saline against which my lungs has to work, and that is not giving any difference during inspiration and expiration, and that's why it is going to be the hysteresis which is not going to be there in the case of saline, which is going to be there if there is air-water interface. So that is the only thing which is going to be there. Okay. Then coming to the regional variation of the lung compliance. What are the regional variations of the lung compliance? Let's see over here. So suppose this is the lung and this is the pleura, and outside it is going to be the chest wall, inside it is going to be the lung. Now understand what is going to happen. Compliance is mainly based on the your pressures which are present and the volume which is going to be changed, right? And that is mainly dependent on transpulmonary pressure, and transpulmonary pressure should be more so as to have the change in the volume, right? So transpulmonary pressure should be more, then the more volume change will be there, right? Delta V will be more when the transpulmonary pressures are changed, and for the transpulmonary pressure to change, we require the change in the IPP, right? And that's why the whole thing, the compliance is basically based on the one pressure, that is nothing but the IPP. Okay, other pressures are important, IAP, no doubt it is important, but the most important is going to be your the intrapleural pressure, right? Don't get confused between intrapleural and intrapulmonary pressure. Intrapleural pressure, that I'm going to talk, right? So if we see the regional variation in the intrapleural pressure, it is very, very clear that how the compliance is going to change in this area. First thing, let's say that I am in the upright position, either standing or sitting. What is going to happen in this case? That my lungs are dilated like this, okay? And this part, which is the least surface area part, this is known as apex, and the downward part is known as base of the lung, isn't it? So apex and the base. Apex and the base of the lung. Now remember, as if I'm sitting in the upright position, what is going to happen? The gravity is acting on my lungs too. So this is going to pull the lungs downward. Now the part which is nearer to the core of the earth, that means towards the earth, it is going to have more pressure as compared to the part which is far away from the core of the earth. That is the normal physics. We know that from bachpan se, right? So if I talk about the apex and the base, yes, there are going to be differences, right? The base is going to have a more IPP. More means less negative IPP as compared to the apex, right? So this is going to be there. I had the diagram, but I think they have not incorporated in this. But remember what is going to happen over here, that at the base we are going to have less negative pressure. How much less negative pressure? Let's discuss that. It is going to have around minus 2.5 mmHg, right? over here it is going to have around minus 10. Let's write in the centimeters of water. It is going to be much easier. Centimeters of water, right? And over here it is going to be centimeters of water. Okay, why I will tell you? Because in between it is going to have like this, okay? And everything should be in the minus. Why? Because the intrapleural pressure, because of the opposite recoil of the lung and chest wall, they'll always be negative. But remember, at the base, due to the gravity, it will have the IPP. At base, IPP is going to be more, or you can say less negative. Minus 10 is lesser as compared to the minus 2.5. That is a simple funda, because we have putting the minus sign in front of that, right? And at the apex it is going to be more negative. Why? Because it is slightly away from the your core of the earth. If you lie down supine, right, this gradient will be evaporated. There will be no gradient, right? So there is a gradient which is going to be present, and because of that, what is going to happen? Gradient of IPP or IPP gradient is present across the lung. And because of this is going to affect the compliance. Now what do you think? If the IPP is more negative, right? IPP is more negative, then what is going to happen? More will be the TPP, right? That means the transpulmonary pressure, because inside the pressure is going to be the same, right? So what is going to happen to the TPP? TPP is going to be more, right? And more suction. Even if you just see over here, minus 10 is there. So that's why there will be more suction applied. Now, there is one more funda applying over here. There is less surface area present at the apex, more surface area present or in the lungs, in the base. And remember, there are few alveoli which are going to be present. Okay, so I'm just drawing 3 alveoli over here, and there are many alveoli which are going to be present at the base. Right? Now understand, if I have only one rubber band and I stretch it, and suppose I have 10 rubber band and I try to put same effort on all of them, definitely I won't be able to stretch them that much. Now see over here, because of both these fundas, there are few alveoli present at the apex, many more alveoli present at the base, and this pressure is also different. There is a gradient which is present. So what is going to happen due to this gradient? See over here, few alveoli are having the suction pressure which is minus 10. The force which is applied on these alveoli, which is going to be much more per unit area of the alveoli, right? Because less alveoli is there, first reason. More suction pressure is applied over there. That means more forcefully these alveoli are going to get stretched up. That means the compliance is much more at the apex, isn't it? So compliance is going to be, so if I see the compliance at the apex, much more at the apex as compared to base. Because of the main reason over here is the IPP difference, right? As you do have IPP gradient, this gradient, even if it vanishes in the supine condition, we do have the number of alveoli, and that's why per unit surface area is going to change. And as soon as the per unit surface area is going to change, definitely there will be change in the this compliance. Okay, so if this question comes, you have to elaborate that with the example and the diagrams, which is going to be much easier for you guys, right? So I hope you understood this funda. Nobody is going to make you understand this, and if you read the Kinong, this is going to take a lot of time, because these points are not jotted down in one paragraph, right? It's a review book. It is going to be very difficult. In the guidance, it is much more difficult, because again they have written the compliance in the another another chapter. In the pressures they have mentioned in the another chapter. So it is going to be very difficult to put all these fundas together which I hope I'm able to convey to you and you understood it very well. If this question comes in the exam, especially Delhi University and UP University, it's very, very important because I have already seen these questions, right? So especially in the Prof, if comes and you write all these points, definitely you're going to give a very good impression on the examiner. So that is all about the regional variation and lung compliance. I hope you understood. More suction pressure available at the apex, and that's why when I'm going to talk about the inspiration and expiration, what do you think? Who will have the more delta C, or who will have more delta V? Remember, if my rubber band is already stretched at the resting condition, I won't be able to stretch it much during the inspiration. But if they are deflated and if I put more pressure, there will be more chances that the volume change is going to be more at the basal alveoli. I know it is going to be a bit difficult to understand because what I told you about the IPP over here, this is going to be in the resting condition. Okay, you just multiply by 2 and you reach up to the apex, right? At the basal condition, 2.5 into 2 minus 5 into 2 minus 10, right? It is in the centimeters of water. If you want to know, it is going to be the minus 8 above on the top apex. Okay, it is going to be the minus 8 and at the bottom it is going to be minus 2 mmHg. So units are going to change accordingly as you are going to change the values, right? Now this is known as double conundrum. What is double conundrum? It is dhoke pe dhoka, which is only given in the boron. This funda is only given in the boron, that upside, though the alveoli are more stretched, but they are more stretched at the condition of rest also. So when we inspire, there is no much of the range which is going to be possible for the expansion. But at the alveoli which are present in the base, they are almost at the deflated condition, right? They have more probability to expand if we start inspiring. Why? Because first thing is that they are already at the less volume state, or they are at the residual volume, they are almost deflated. They do have more chance or probability, or they have more space available, more dynamicity available, so as to stretch it, right? And the air is going to come there. So please remember, the ventilation is going to be more at the base as compared to the apex. Why? We'll see that as in soon when we are going to come towards the volume lungs capacities, right? Yesterday I have drawn a very pathetic diagram, I know, but yeah, this is the diagram which I wanted to show you, and that's why I have downloaded the diagram and specifically I bought it for you. So see over here, what is the difference that we can see? First thing is that there is a drum which is available, that is we can call it as bell, inverted bell or inverted cylinder, which is going to be there, and this is the cylinder through which we are going to inspire. This inspiration tube is attached towards the bell. Actually it is not a single cylinder. In the conventional spirometer, they do have double wall cylinder. So there are 3 cylinders which are present, 2 normal cylinder and 1 is inverted cylinder, which is known as bell, right? In between the inner cylinder, this is the inner cylinder, outer cylinder, in between these two we do have water, and not in between the bell and the, so this will be something like this. Okay, so a little bit faulty diagram because I have picked up from the net, right? But yes, there are 2 cylinders which are present, inner wall of the cylinder, outer wall of the cylinder, and the inverted cylinder, that is going to be the bell. In the inner wall and the outer wall we do have water, not in between the bell and the this thing. The bell has bell is going to get incorporated in what thing? Rather I should draw this. So inner cylinder, outer cylinder, in between the inner and outer we do have bell. Okay, so as to make the airtight seal, we are going to put up the water into it, fill up the water into it, 3/4 of the cylinder height, cylinder's height. Okay, and then with the help of the pulley, you can see over here, this is the pulley through which this bell will be connected to a lever which is going to give us the graph on the paper. Okay, what are the types of volumes and capacities are present? First is the static and then the dynamic. What is the difference? In the static, we are going to just measure the volume or the capacities, right? Change in the volume or capacities. In the dynamic, we are going to check the change in the volume per unit time. So we are measuring the duration in the dynamic. So please remember, D for dynamic, D for duration. That means we are taking the time into the consideration, and in the static we are not going to bother about the time. Okay, so time is going to be taken into the consideration when we are measuring the dynamic type of volume and capacities, not the static ones. Okay, what are the static ones? All of them are static ones, which we have talked already yesterday. So if you can tell me quickly, this is inspiration and expiration. Inspiration will give me the upstroke and expiration will give me the downstroke. And suppose I ask the subject to inspire, expire, inspire, expire normally, right? Then I ask him to inspire forcefully and expire forcefully, and then again inspire, expire, right? So the graph I'm going to get over here, the normal inspiration and expiration. So this is going to be the inspiration and downstroke is for the expiration. This is known as tidal volume. It is around 500 ml, right? The extra amount of air, I'm not going to include the tidal volume into it. It is going to be the IRV, inspiratory reserve volume, which is around 2 to 3 liters, right? Ginong specifically mentioned it is as 2 liters, so I'm writing 2 liters. Most of the books write it as 3 liters, right? And if we talk about the ERV, that is expiratory reserve volume, the extra amount of air which is expired out during the forceful expiration, excluding the tidal volume, that is known as the expiratory reserve volume. It is around 1.2 to 1.3 liters, right? And no matter how forcefully you expire, there is some amount of air which is going to reside into your alveoli. This is known as the residual volume. It is around 1.1 to 1.2 liters, 1.1 to 1.2 liters, right? And if I measure the capacities, what are the capacities? Capacities are nothing but the summation of 2 or more volumes. Okay, so at least 2 volumes you have to measure, right? So if I make this thing over here, yes, Roy, you are right, inspiratory reserve volume. And yes, if I measure the TV plus IRV, it is going to be the inspiratory capacity. I'm just writing the short forms because again we are not going to have much of the space left otherwise. If I combine these two, that is the tidal volume and the ERV, that will be called as expiratory capacity. Now these can be coming out into the spirometer, and this is known as vital capacity. Now there is one more term regarding this. It is called as FVC, that is forced vital capacity. What is the difference between vital capacity and forced vital capacity? It's one and the same in the healthy person. It's just that you're using the force, right? So the time is taken into the consideration when we are going to measure the forced vital capacity, and this is taken under the dynamic this volume and capacity, and not under the static ones, right? But remember, the vital capacity and forced vital capacity in the normal healthy person is going to be same. But definitely, if the person is having disease, that means if there is a lesion in the lungs or there is any disease in the lungs, it is going to get affected. Now, what is the effect? The FVC can be reduced. For example, if you have obstructive, by you, any patient have obstructive lung disease, what is going to happen is that the VC can be normal, but the FVC will be less. Why is it so? We'll learn later on. Okay, just trust me right now. And if I combine this two things, that is the ERV and RV, this is going to be FRC, that is functional residual capacity. And if I combine all of them from top to bottom, this is going to be TLC. Now, the diagram that I have shown you before, that whenever I'm going to inspire or expire into this bell, then I'm going to get the graph. But the volume which cannot come out of the lung, that cannot. So the person expiring and inspiring from here, so whatever amount which is coming out of the lung through the mouth, it is going to go in this. But whatever amount of air that remained into the lung, I'm not going to get the graph of it, isn't it? So that's why please remember that whenever the RV is going to come into anything, we cannot measure that volume. So first thing we cannot measure is RV. This is the amount of air which is going to reside into the lung after the forceful expiration, right? No matter how forcefully you expire, the residual volume is not going to come out. So whatever capacities are containing this RV, we are not able to measure them with the help of spirometer. So the instrument is known as spirometer and the procedure is known as spirometry, right? This is measured under the pulmonary functional test. The question can be asked on the pulmonary function test. The instrument is called as spirometer and the procedure is known as spirometry. Okay, now understand that it cannot differentiate at what point the air has started to come and from which part of lung. It is not going to give us that information also. Yesterday, two more things we learned in this graph. What was they? They were that I told you that the basal alveoli, I told you that there are few alveoli present at the apex and many alveoli which are smaller in size which are present at the base. So that means when I start to expire, the equal pressure has been put on these two alveoli. So the basal alveoli, they have tendency to close first. Okay, I'm not going to use the word collapse over here because the RV is going to stay inside them also. So what is going to happen in this case? That the basal alveoli will close first. That means the basal alveoli I can say, or if I'm lying down supine, that means whatever posterior side alveoli, the better terminology is the dependent part alveoli. So whatever is the dependent part, those alveoli are going to close first because of the effect of gravity, right? And whatever independent part or the top part is there, they are going to close later on. So as soon as the dependent part alveoli are going to close, after that whatever amount of air comes through the expiration, this is known as the closing volume. And if I add up the residual volume into the closing volume, that becomes the closing capacity. That becomes the closing capacity. Okay, what is the closing volume? The amount of air expired after the onset of closure of the dependent part alveoli. Okay, so that is the closing volume. I hope you understood this graph, and you can calculate on the basis of the volume, you can calculate the capacities also. Okay, now the residual volume is the amount of air which is going to reside, residual, right? It is going to reside inside the lung after the forceful expiration. No matter how forceful you do, this air won't come out. Now what is the significance of this? Is there any benefit that we are getting of having the residual volume? Yes, definitely there are going to be two benefits that you have to tell. First benefit or first significance is that it prevents the collapse of the alveoli. Which is also known as atelectasis. Right? The second thing is, if you have residual volume, what is going to happen? First thing, see over here that this is the alveoli, and I told you in the lungs you do not only have the alveoli but also you have blood vessels, isn't it? Now what is going to happen? The blood is continuously flowing. It is not dependent on the inspiration or expiration, isn't it? So if the blood flow is not dependent on the inspiration and expiration, what is going to happen during expiration? The blood will still continue to flow in the blood vessel or pulmonary vessel. If there is no amount of air that is there, how the gas exchange will be formed? So gas exchange, if the residual volume is not there, definitely it will be interrupted gas exchange which is going to take place. Okay, during expiration, if there is no amount of air, the gas exchange won't take place, right? In the blood, in between the alveoli and the pulmonary vessel, right? And that's why for the continuous gas exchange, we require this RV. Okay, continuous gas exchange, that means even during the expiration, the gas exchange, the exchange between the, even during even during expiration, the gas exchange, that is the exchange of oxygen and carbon dioxide, that continues. Okay, so two main significance. Okay, they can ask you about the cause of the residual volume also. I don't have time, otherwise I would have discussed that too. The residual volume is because of, if you get the time, remember to read about the DCA, that is your homework. What is DCA? I'll just tell you the full form over here. Dynamic compression of airways. Especially in this case, we talk about the intrathoracic airways. That is the hint, because the extrathoracic airways, they do have cartilages, and that's why we are not going to include them, right? But again, some of them won't have it. So just read about the dynamic compression of airway, that is the cause of having the residual volume inside the lung. There are two different questions and your answer will change according to the question. If they ask cause of the residual volume, your answer will change. If they ask what is the benefit or what is the significance, don't tell the dynamic compression of airways. It is going to be the benefits that is written over here: atelectasis prevention and continuous gas exchange, right? What is the closing volume? Closing volume is nothing but the amount of air expired by the subject after the onset of closure of alveoli in the dependent part. Okay, in the dependent part, when they start to close, so alveolar closure in the dependent part, whatever amount of air that is expired into the spirometer, and if we add CV plus RV, that is going to be CC. Okay, now why this CV is important? Because understand, when we are going to have diseases, in that diseases the CV and FRC, usually the FRC is much more as compared to the CV, isn't it? FRC is more FRC, not FRC, the ERV. So FRC, if I show you the relationship between these two, see over here that yes, the FRC is going to be more as compared to the CV, isn't it? Or as compared to the CC I'm talking about, right? But as soon as the age is going to be increasing, in the progressive age and in the progressive diseases, this relationship is going to get closer, and even the closing capacity can be increased more than the FRC. This is quite possible. Okay, so this is possible, and that's why this is very important to know where is the CV and how this is occurring over here, right? Now, what the capacity is, just quickly discuss this. TV, that is the tidal volume, plus IRV. EC is what is the TV plus ERV. FRC is what? FRC is ERV plus RV. VC is IRV plus TV plus ERV. I can even write inspiratory capacity plus ERV, or I can write EC plus IRV. It's one and the same thing. I can write TLC minus RV also. One and the same thing. No matter what formula they are going to give, if you know the graph, you'll be able to solve the question, right? All the volume, that is IRV plus TV plus ERV plus RV, is going to be the total lung capacity. I can write in the different format as I have written about the vital capacity also. What is closing capacity? It's the CV plus RV, right? Now remember, the CV, the spirometer won't be able to measure. Volumes and capacity cannot be measured. Let's write like that. Volumes and capacities cannot be measured by spirometry. What are those? First of all, I told you whatever is containing RV, we cannot measure that. So first of all, RV itself we cannot measure, right? FRC we cannot measure by the spirometry. The TLC cannot be measured, and even it cannot distinguish between the CC and ERV, because it is not going to tell. Spirometer won't tell us that when the basal alveoli or when the dependent part alveoli has been closed, and that's why we cannot distinguish between that, and CC cannot be measured. CV cannot be measured, and again in the CC we do have RV. So these 5 things we cannot measure, these volumes and capacity we cannot measure with the help of spirometry. For that we require different instruments and different methodology that we have to apply to measure all these things, right? So let's move on forward. Vital capacity. Remember, it's very important to measure the vital capacity. Why? Because physiologically it is also going to change, and then later on when we are going to talk about the dynamic volumes and capacity, it is also going to change there, right? So can you tell me in which condition physiologically the vital capacity is less in? I'm talking about physiological first. Pathologically, in many conditions it is going to be less, but physiologically the VC is less in many conditions, such as, yes, tell me what are the conditions in which the VC is going to be less. First, if the subject is having smaller thoracic cavity, that means for example the females, they do have smaller chest cavity or thoracic cavity, right? And they do have less muscular power, and because of which it is going to have lesser vital capacity. They are going to have lesser capacity as compared to the males. Children, they do have smaller chest cavity, that's why they are going to have lesser vital capacity. Not only that, the pregnant ladies, they are going to have even lesser vital capacity. Why? Because the uterus, it is going to push the diaphragm upward, so we will not be able to increase the vertical diameter of it, isn't it? And because of that it is going to be lesser in this case. Not only that, in the old age we are going to lose up the elasticity property and the contractility or the force of contraction which is produced by the muscle, which is going to be lesser. So that's why in all these conditions this is going to be lesser. Yes, in the obesity also it is going to be lesser, right? Obese person, usually they do have lesser lean body mass, which is known as the body mass minus the fat. Okay, fat won't be helping us in the integrity of the muscles, right? And that's why it is going to take up space but not going to give us any strength to contract the muscles, right? So that's why pathologically there are many conditions which are going to have a lesser of the vital capacity. We don't have much of the time, so that's why we are just going to hurry up this. That helium dilution method, I told you that the FRC cannot be measured by the spirometry, and that's why we require different methodologies. We are going to use helium dilution method in this case, right? And helium dilution method, that means same it is as a dye dilution method, it's just that we are going to ask the subject to inspire it. Okay, so it is going to be the diluted air with the helium. Okay, and how we are going to calculate? So what is the formula over here? The V1 and V2 we are going to use, that is the initial volume and the final volume. The final volume we are going to take as the FRC. The V2 is nothing but the FRC, right? It will be equal to V1 into C1 minus C2, that is the initial concentration of the gas minus final concentration upon final concentration, right? So what is V1? V1 is initial volume, right? V2 is final volume, then C1 is initial concentration, C2 is final concentration, right? And the V2 is nothing but we are taking it as FRC. So with the conservation of mass principle, we are going to apply that over here, and this is the method that you have to at least know the name, that is helium dilution method. Nobody is going to ask you much in the detail, but it is important, right? But the best method to measure it is going to be the body plethysmography. In that, what we ask the subject to do is that The subject's pressure and the box pressure. We are going to ask the subject to sit into the box, and we are going to measure the pressure changes into the box as well as in the lungs. Understand, over here, this both will be constant. It is going to made constant. So whenever the person is going to inspire or expire, the volume as well as pressure changes, whatever are happening in the lung, the opposite changes are going to happen in the box. So for example, what I'm saying is, let's say during the inspiration, what is the pressure change and volume change is going to happen in the box, the exact opposite change is going to happen in the lungs, right? So I'm going to attach the pressure transducer to the box, and I can measure it into the lung directly also, right? So pressure, what is going to happen to the pressure into the lung? We know the negative suction pressure is created, and as soon as the pressure falls during the inspiration in the lungs, I know the pressure in the box is going to increase. Why? Because the system is maintaining the pressure constant in both the things, right? So ultimately it is going to be constant, and the opposite is going to happen applying the Boyle's law. The volume is going to increase over here, and reverse, the volume is going to decrease. So if we plot the graph over here, the pressure versus the mouth pressure, you can see that the graph is inversely proportional. If you increase the box pressure, definitely the mouth pressure is going to decrease, okay, and vice versa. This is going to work. This is the only thing you have to remember. If we get time, I'm going to make a separate video on all these conditions, but this is mainly important for the postgraduate and DNB people, because they do have long question on these methodologies. In the UG thing, they are not going to ask much question on these, but definitely they can give you the graph, or they can give you simple questions, and they can ask you what is going to happen or what change you are expected to have. Right. The next thing that we are going to discuss is the nitrogen washout method or Fowler's method, which is going to be very easy. We can discuss that in the brief, and then we can move on to the next thing, that is the question answer session. Now, nitrogen washout method is similar to the helium dilution method. In the helium dilution method, we do have a bag in which we ask the subject to inspire, expire, inspire, expire into the bag again and again. But when we talk in terms of this nitrogen washout method, please remember, this is going to be the simple method which is going to be there, right? So this method is going to be the one, nitrogen washout method, which is the single breath nitrogen method. Okay, that means we are going to take a single breath, and we are going to ask the subject to take a breath and leave the breath. Then we are going to measure the concentration that is present, nitrogen concentration that is going to come into the pressure transducer, or concentration, that is sensor that is there, right? Now understand, if I plot a graph of it, how it is going to happen. First of all, from the mid inspiration position, I'm going to ask the subject to inhale 100% oxygen, that means pure oxygen. What I'm going to do is, I'm going to ask him to forcefully inspire, but I'm going to interrupt him in between, and I'm going to attach the 100% concentration, and I'm going to pinch the mouth, and I'm going to ask him to breathe in. What is going to happen because of this, that during the first half, the atmospheric air enters into his lungs, right? And in the later half, the 100% oxygen is going to enter into his airways. Okay, why? Because whatever air is going inside, first of all, it will go through the trachea and push downward towards the alveoli. And later on, when I'm going to ask him from the mid inspiration, I'm going to ask him to inhale 100% of the oxygen. The later half of the airway tract, which is going to be having the oxygen and only oxygen, it won't be containing the nitrogen. One more funda that we have learned already, that the upper airways, they are the conducting airways till the 16th generation, isn't it? That means there is no exchange. And if there is no exchange, that means 100% oxygen is not going to get exchanged, and that will remain as it is. So that means when he is going to start expiring, from where the air is going to come first? from the uppermost part, that is the trachea and the conducting airways, where there is no exchange, and the later part is inspired there. That means 100% oxygen is going to come. There will be 0% of the nitrogen concentration which is going to come. So if I make a plot a graph like this, so you can see that this is the nitrogen concentration and this is the expiration that is happening. So this is a very blurred graph. Just let's make it on our own. So on the y-axis, I'm going to take the nitrogen concentration in the percentage, right? I'm just writing N2 CN2, that is concentration of nitrogen in the percentage, and expiration. The process of expiration is going to continue forward, right, as much as he is going to expire. So I'm just going to plot the graph, or I'm going to see how the concentration is going to raise. Then what I'm going to see over here is that, first of all, as the person will start to expire, what is going to happen in the first phase? The first phase, the oxygen concentration is going to be much more. Why? Because it is the 100% oxygen and not the nitrogen. Please understand. It is the 100% oxygen which is going to come out. Why? Because there is a conducting airway in which the air has gone later on, and that was 100% oxygen. Conducting airway, that is why there is no exchange. So as it is, the 100% oxygen will come out. But we are not measuring the oxygen concentration. The name itself telling the nitrogen washout. So we are measuring the nitrogen concentration. So that's why the nitrogen concentration is going to be 0. As soon as the later on the person will start to expel the air, what is going to happen? See, the nitrogen concentration is going to build up steadily and gradually. So this is the phase 2. What is going to happen in the phase 2? That whatever anatomical conducting zone was there, from there as well as from the exchange zone, the air start to come out. And that's why the nitrogen concentration is going to increase steadily. Remember, in the first, it is the dead space area from where only conducting airways, from where the air is going to come out. The nitrogen concentration increase, that means it is coming out from two areas. First is the mixed air coming from two areas, that is, first is the conducting zone and the exchange zone, right? But later on, what you are going to see is that there is a steady concentration which is going to be maintained. So this concentration start to rise in the second phase, but later on it is stabilized. Okay, that means now the air has been started to come from the alveoli itself and the alveolar ducts. Why? Because all of the alveoli, they started to excrete, and that's why it became a plateau right now. But suddenly what you see after that the nitrogen concentration suddenly increases. Why is it occurring? There are two reasons for this. Just remember that this is the phase 4. Okay, why this is going to happen and why this is happening in this condition? See over here that because I told you that as soon as the person start to inhale, the air has tendency to go upward first, right? So it is going to fill up as soon as the person will start to inspire. In the beginning of the inspiration, as soon as he is going to start the inspiration, the air will be filled up into the alveoli that are present in the apex. But later on, because there is no much of the alveoli which are present, and the compliance is much more in the later on alveoli, that is the basal alveoli. Why? Because they need to stretch. They take time to stretch, and that's why the later on air is going to go in the basal area. Okay, so the air will, first, it is having the tendency, and second, the compliance of the upper part is much more, because they do have what thing, or we can say they are already stretched. So that's why there is a space available in the above alveoli. So the ventilation which is going to happen, that is going to begin with the apex wala alveoli, and then the air will start to fill in the basal alveoli. So A for base and B for later on, right? A comes first, then the B. So that's why, first of all, when the person was inspiring the atmospheric air, the air has gone into the apex wala alveoli, right? And later on it has come down to, whenever the person start to inhale 100% oxygen, it started to come into the base. So yes, the mixed air will be there in the basal part also, right? 100% oxygen plus nitrogen, some amount of atmospheric air. Now, since I told you that these alveoli are smaller and they are going to close first. So as soon as they are going to close first, what is going to happen? The remaining air, when the person will start to expire, this air is going to come from the apical alveoli and the middle part alveoli. That means this air has started to come after the onset of closure of the alveoli in the basal part, and whatever amount of air that is going to come after the closure of the alveoli in the dependent part, that is called as CV. So the fourth thing is just going to be the CV, which is going to be the closing volume, which can be seen over here, right? It seems a bit confusing, but don't get confused. This over here is going to be the CV, okay? And whatever remaining air is going to be there, this is going to be the RV, right? Which we cannot measure, but this is going to be the CC, which is going to be there. So I'm expanding this a bit over here. So this will look like something like this, okay? So first, second, third and fourth. Now understand, I can measure the anatomical dead space from this also. How? I'm going to part the phase 2 into two parts, and whatever the midway is going to come over here, I'm going to take this as the anatomical dead space. So please remember, because this air is coming from the conducting zone where there is no exchange. What is dead space? Dead space is the space where the amount of air lies which is not going to get exchanged. So this is the amount of air which is not getting exchanged, and that's why this is known as the dead space, okay? So I don't have much of the time, so please remember this graph is very, very important, which is given in the Ginong, Guyton and each and every book. But I'll suggest you to read Guyton in this case, because the explanation is more elaborative in that book, okay? So Guyton is better as compared to the Ginong in this explanation of this Fowler's method, okay? It's given by the scientist which is known as Fowler, okay? If you want more explanation on this, I have the YouTube channel, right? That is Mixmark, or you can just put my name and you're going to get since I'm busy in this classes, so I haven't put many of the videos, but the Fowler's method video is going to be there, okay? So if you want to learn that elaboratively, you can go and watch them. What is this VD? VD means ventilation in the dead space. So dead space, and you can see over here that in the middle of it, they have parted the ways, right? In the phase 2, in between they do have vertical line which is drawn over here, which is from the middle of the phase 2, and from here to here they have measured, from this value they have measured the VD, that is the dead space, okay? And we have already discussed in the phase 4, as soon as after the plateau, whatever the increment has been started, that is nothing but the CV and the RV, which we cannot measure with the Fowler's method also, right? So this is the summary. You can just go through it. First is going to be the anatomical dead space. Second is going to be anatomical dead space plus the alveolar gas, which is going to be the mixed air which is going to come, right? And that's why we have parted the way in between. Then third comes the alveolar gas, which is relatively stable nitrogen concentration from all the alveoli, small air, dependent part, middle part and the apex part. That means all the alveoli, they're going to have mixed air, and then the basal part alveoli will close over here. So poorly ventilated area are going to have this fourth phase from where the air is going to come, and this is the CV, right? So fourth phase is going to be the CV, okay? That is the closing volume. We don't have time to discuss the whole thing of this dynamic volume. I'm just going to mention the Tiffany-Pinelli index. What is this index? We divide the FVC. We ask the subject to expire forcefully. As soon as these expire forcefully, not only forcefully, as quickly as possible. So as he is going to expire forcefully and quickly, Ginong says that it takes almost 3 seconds. So that's why we have divided into 3 seconds, that is FEV1, FEV2 and FEV3. What is FEV1? The forced expiratory volume. During first second. first second, and this is during first 2 seconds and during first 3 seconds. What is the value of this FEV1? It is around 75 to 80% in the normal person, right? And you just remember 80, 90 and 100% air won't come out, so we are going to write it as 95 to 98%, which is going to come out in the phase 3. You can remember 98 to 9 in the air we can write 98 to 100%. Usually 95% also comes in most of the condition. It can take 4 seconds also, right? So just remember, we have to calculate the FEV1 percentage, and that is nothing but the definipinally index. Okay, so I'm going to just rush through it. I hope you know this. FEV1 percentage is nothing but the definipinally index. I'm going to calculate the FEV1, how much amount of air out of the total expired air, that is the forced expiratory volume, into 100, that is going to be the FEV1 percentage, and that is nothing but the definipinally index. If there is an obstructive lung disease, remember what is going to happen. If there is an obstruction, the numerator will fall, right? Obstructive lung disease may all the air can come out, but it is going to take more time, and that means during 1 second less air will come out. If the less air is coming out, that means FEV1 is going to be less, but the FEV1 is normal. What is going to happen to the ratio? If the numerator is less, the ratio will be less too. On the other hand, in the restrictive lung disease, both are less. That means the FEV1 is also less. But remember, in initial condition, it can be normal. As the severity progresses, this is going to decrease. But remember, the FVC, this should be FEV, FVC, this should be FVC. This should be FVC. That is the total amount of air which is coming out, forced vital capacity. So FVC is going to be decrease a lot. Why? Because the amount of air that has been going in the area, that area is defective now. This is filled up with the fibrosed fibers, and that's why fibroblasts, which do not have much of the elasticity, right? So that's why that is going to be the one which is going to reduce more, and that's why the ratio, either it is going to be normal or even it can be increased. Okay, so just remember, in the obstructive lung disease, in old, the ratio is going to decrease. Just remember that. Most of your questions are going to get solved. Okay, let's move on forward. This is the same graph which is given. You can see just briefly that in the OLD, in the old, what is going to happen? The FEV1 percentage is going to decrease. In the restrictive, rather it is going to increase. I told you it is around 75 to 80%. You can see over here, in this person specifically, it is 83%. So definitely his FEV1 is pretty lot better than average person. Okay, so with this message we can move on to the questions directly. Resilience is knowing that you are the only one that has the power and the responsibility to pick yourself up. No matter what condition you are staying at right now, just pick yourself up, right? So that you can move ahead in your life, and you and only you have this ability. So resilience is important, persistence is important. I always say courage to continue is important. No matter how tired you are, no matter how much painful your throat is, still I'm taking the class, because today was the day when I did not have the class, but since there is Rakhi coming and many other things are coming, right? So the class has to be postponed because the staff is going on chutti, right? So the time for the quiz, just breathe and solve the question. Okay, so next let's take 5 to 10 minutes to solve the question that we have discussed, right? So solve this question quickly. The COPD patient is there. The question number 1, I want the answers from you guys. Question number 1 is saying that there is a COPD patient. COPD means it is the obstructive lung disease. I have given you the hint. So tell me what is going to happen to the definipinally index and FEV1 per se. What is going to happen? Option A, both is going to decrease. Option B, the FEV1 and FVC is going to be more. The index is more and the FEV1 is more. The index is more but the FEV1 is less. or vice versa? Just tell the answer. Okay, thank you, Roy. Chalo. From the Shivam and Varun, I got the right answers. I'll move on with the answers because we don't have much of the time. I told you just now that the obstructive lung disease, in that the FEV1 will be reduced, and that is the reason why the ratio is also going to reduce. That FEV1 percentage is also going to reduce. In the OLD, the FEV1 will be reduced and the FEC is the normal. Denominator is normal, but the numerator is starting to fall, and that's why what is going to happen is the ratio of these are going to fall. The values have changed a little bit. Why? Because to confuse you. There is no relationship of these values. And remember, whomsoever solved this question, even Jiva solved this question, give yourself a pat on the back. Why? Because this was the AIMS question. AIMS question, which is came in the 2020 or 2021, just after the COVID. I guess in 2021 this question has been coming. This is the AIM question, and you have solved it in your first year or whatever you are in your, right? So this is the question. Second question, healthy adult male, expected volume of air expired during each normal breath. So during the normal breath, this is the hint over here. I have made the sheet, right? So what is the answer of second question? Tell me the answer of second question. Then comes the third question. Answer me of second question. Very easy question. Very good. Roy, Varun, Shivanshu, Shivam Raj. Just check your answer, Vijay. Yes, you are absolutely correct. All of you are absolutely rocking. So this is nothing but normal breath. That means they are asking about the resting condition, isn't it? And that means they are asking about which volume? They are asking about the tidal volume, right? Let's move on forward. 54-year-old male came to medicine outpatient department, that is OPD, with a history of persistent cough, breathlessness, loss of weight. He is diagnosed with pulmonary fibrosis. Which of the following can be expected in this patient? First of all, this is the case scenario, but still you can solve this question on the basis of the information that we have. Pulmonary fibrosis is there. If I talk about pulmonary fibrosis, what type of disease is this? Is it obstructive lung disease or it is the restrictive lung disease? First of all, tell me that. On the basis of that, you can easily solve this question because it's very easy if you just sort this out, that when fibrosis is obstructive or restrictive. Yes, I'm already getting the answers right. I'm very happy that all of you are giving the right answers. Very good. Yes, Shivam Pras. Yes, Roy, you were right. You will go with restrictive. Okay, so you are going in the right direction, Roy. So you will go. I'll go with Shivanshu Agrawal. Yes, you are right, bacho. So fibrosis is always restrictive. There is no obstruction in between. Why? Because whenever in any area, suppose if restrictive lung disease, that means pulmonary fibrosis, this fibers has been, the elastin fibers, they are replaced with the fibrous tissue, that is nothing but the fibroblast, and they don't have any property to contract or relax, stretch or recoil. Okay, and that's why we are going to call it as restrictive lung disease. There is no obstruction in the airways per se. What is going to happen in the expected patient? Is it going to be the FVC which is going to decrease and normal FEV1 and FVC? That's true. In the first case, this is going to happen, but understand either the FEV1 or FVC, that is going to decrease, or both can be decreased. So my better answer over here, already persistent cough, breathlessness and loss of weight, that means the condition is worsening now, right? The FEVC cannot be increased, right? So these two options are out already, right? And I know that if the denominator is decreasing, what is going to happen in the restrictive case? We have just seen In the restrictive RLD cases, what is going to happen to the FEV1? FEV1 will be normal, but FVC is going to reduce a lot, right? FVC is reduced a lot, and this is reduced a lot. So always remember the ratio is going to reduce a lot. FVC cannot be normal. The forced vital capacity, that means the total amount of air that is expired, this cannot be normal because most of the area, the area which is fibrous, that is not functional now. Okay, and that's why over here both are going to decrease, right? The FVC is decreased, yes, and the FEV1 either normal. So yes, the ratio is not going to decrease. The answer is going to be A over here. Varun, you gave answer D. Why, bache? FVC is not going to increase in the pulmonary fibrosis. Yes, answer is going to be A over here. Okay, next question. FRC, ERV and RV is given, right? What you have to see is just FRC. FRC, how you calculate the FRC? The formula is given. Answer me this question. Question number 4. Few questions are remaining, then we are going to sigh a lot. Remember, during the sighing and yawning also, the magnitude of your contraction of your muscles, especially the inspiratory muscle, it is increased. So it is said to be, good to yawn or in between you sigh. That is good for your muscles. Not always, but yes, sometimes. Yes. All of you given me the answer FRC. FRC is what? Functional residual capacity. We have to add up these two values, right? So this was the tidal volume, IRV, ERV, right? And this is again tidal. So I told you that if I divide this, this is going to be my ERV, and this is whatever amount of air that is going to remain, that is going to be RV. If I combine these two, this is going to be FRC. So if I combine these two both, absolutely right, Varun, Shivanshu, Roy, all of you, Sahil, very good. So all of you are right. So it's very easy question, isn't it? This question again came in the NEET PG. Solve this question and tell me what is going to be the answer of this question. Fatafat say what you have to calculate. I'll just make it easy for you. That the person is inhaling the air, right? As much as, that means as much as air possible, that means forceful inspiration, that it is saying, okay? And produce maximum expiratory flow volume curve, right? What they have asked is forced vital capacity. FRC is asked, right? Vital capacity or forced vital capacity that you have to measure. What is the formula for forced vital capacity? How you are going to measure it? The lung volume, the total lung volume is given. Now understand that you can see that the person's volume is increasing in this order, right? That means, first of all, as he started to expire, this much amount of air has come out during the expiration. As he started to expire, that means he started to expire at this point, isn't it? And he stopped over here. So whatever amount of air is remained over here, that is going to be the RV, isn't it? So this, this is not RV, this, I have written this ulta, that is this amount. They have written that they have given the volume in the lungs, isn't it? So lung volume is given, not the spiromotor volume. So that's why the funda is, it will be reversed, that this is going to be the RV, which is going to present in the lung. Why? Because they are not measuring the volume of the spirometer, they are going to measure the volume of the lung. So whatever amount of air that is remaining inside the lung, that is RV. How much is the RV over here? That is 1 liter, right? And around 5.5 liter is the volume over here, okay? So 5.5 is the volume over here, right? 5.5 is what volume? It is going to be your total lung capacity, isn't it? So total lung capacity is 5.5. Right. So what you have to do is to find out the vital capacity. What you have to do, see over here, we have made this diagram, so we'll just add it. This was vital capacity, isn't it? And this is the total lung capacity. I just have to subtract the RV from the total lung capacity, isn't it? And that's how I'm going to get it. So the TLC, that is 5.5 minus 1, that is going to be 4.5, is going to be the answer over here. Easy? Yes. I've got the answer from Aditya, Roy, Sahil, Shubham. All of you are wonderful. You're giving the right answers, and trust me, nothing makes me happy more than that my students understood this. Okay, right? So yes. Next question: a patient with a respiratory volume of 500 ml, the intrapleural pressure measured is -4 centimeter of water before, and later on it became -8 at the end of inspiration, because it is going to get more negative. Volume that they have told is 500 ml, right? And you have to measure the compliance. What is the formula for compliance, bacho? Formula for compliance is delta V by delta P. We are going to check what is the change in volume per unit change in pressure. After changing the per unit change in pressure, what is the change in the volume that has occurred over here? So tell me what is going to be the answer. Volume over here they have given is 500 ml, isn't it? Now we have to check the delta P. Delta P, that means what is the difference between these two pressures? What is the difference? -4 minus -8, right? So even if you do that, it is going to be around 4, right? So this is going to be -8 to -4, this is going to be 4, and your volume, the value that you are going to get is going to be 125 over here, 125. Okay, the change in the volume from the -4 to -8, it is going to be 4 centimeters of water, isn't it? So that is going to be 125. I got the answer from Shivanshu and Sahil and Roy. Correct, very good. Okay, chalo, tell me the answer of this. Very easy question. I have told you the trick also. You don't have to learn, look at the question even. If you see the graph and you can see the options, you are going to give me the answer. If you remember my trick, how to remember, even if you don't want to apply your brain and you want to save your time, there is a smart trick by which you can, give me the answer of this. Yes, I got the answer from Shivanshu and Sahil. You're absolutely correct. What is the answer over here? The A which is shown and B over here which is shown. A, I told you C comes first and then L will come, and in between what we are having, this blue color integrated wala diagram, this is nothing but the average of both these two. Okay, so that means, and they haven't asked about this blue color, rather they have asked about the X. Where is the X? So see over here. So this is the X. That means they are not asking about the whole thing, they're asking about this point which is denoted over here, right? So they have asked about this point. What is this point? And I already told you that this is nothing but the functional residual capacity, where the transmural pressure of the lung and transmural pressure of the chest wall, they are going to be equal and opposite, and that's why this is the relaxing volume and relaxing pressure. A is the curve of chest wall, C comes first, then the L will come, and that's why the answer over here is going to be option C, C and C. That is the correct answers that you are giving me, right? Roy, Shivanshu, Sahil, yes, you are rocking. Okay, closing capacity. Chalo, ye bhi answer you can give me by the discussed concept, right? So give me the answer of this. I'm waiting for it. Two option you can just exclude it out. Why? Because medium sized bronchioles, they're not going to be discussed in the CV or CC, right? We always discuss about the small ones. Okay, so two options are already out. So I'm giving you the hint. Medium size, okay, this is not visible. So medium size airways that we talk usually, they are not going to come in this. Okay, so these two are already out. So what is going to be the answer? Chalo batao bacho. Closing capacity they are asking. It is related to, yes, dependent portion. Very good, Roy. Anybody else would like to try? Do as many mistakes as you want, just do not repeat those mistakes. That is the success mantra. Okay, Sahil, Sahil bache, you want to change the answer because they have said non-dependent part. Non-dependent part means apex, but I'm happy you tried. Okay, so it cannot be that. Okay, without cartilage, first of all, understand without cartilage, both are without the cartilage. Why? Because the alveoli do not contain any cartilages, right? So they have given just to confuse you out there. And once the dependent part alveoli close, especially in the upright posture, this is the basal part alveoli which are going to close first, and that is going to give us the closing volume when we add up to the Sahil. Okay, I addressed you. Mohammad Said, yes, you are correct, and Shivanshu, you are also correct. And give me the questions answer. I know I'm going to exceed the time. I hope that in 2 minutes I'll finish it. Just give me the answer of this question. 55-year-old male patient, COPD patient hai, right? So see over here, COPD patient is there, right? What they are saying is reduced FEV1 and ratio, both are reduced, right? What they are asking is tidal volume. Stupid question, no relation of this question with this case scenario, but this is what the NBE is expecting us to solve, right? Unnecessarily. Question is going to come in a longer format. You just have to pick up what is important information for you. You can see the options and you can read the last line. That can make up the most of the part of the question. Chalo, give me the answer. Very, very easy. No answers. I'm not getting any answers. Tidal volume कैसे calculate करते हैं? How to calculate the tidal volume? Very easy. There's no need to get confused with the COPD patient. Let's say X का answer. Okay, I don't know what is the number. I'll just randomly can write question number 9. Yes, I got the answer from Roy. Anybody else want to try? Absolutely correct. That this is the TV, IRV, ERV, and this is going to be the RV, which is going to remain there, right? I want tidal volume, so what I'm going to do is this is the IRV and this is the inspiratory, that is the tidal volume, right? So if I minus the IC, okay, sorry, this is not IRV, IRV is this one, IRV, and this whole is IC. If I subtract the IRV from the IC, I'm going to get the tidal volume. So option C is going to be the answer over here. Option C is going to be the answer over here. Let's move on. Okay, last question. Answer. Shivanshu, I got the answer? Yes. Roy, I got your answers already. Sahil, check your answer, Piche. I think you have given the answer for the question that I asked before. Maybe there is some lag. Okay. So see over here, what are the information that is given? Respiratory rate is given, tidal volume is given, inspiratory capacity is given, and expiratory reserve volume is given. What we have to calculate is inspiratory reserve volume. Again, all the information is not a necessary information, right? Via the two inspiratory reserve volume you have to calculate. Give me the answer. Till that I'll make the diagram. This is TV, this is IRV, right? And again this is IC is given, EC is given, IC is given, and EC is also given. Now if I write the values over here, you'll quickly understand what we have to do over here. They have asked about the inspiratory reserve volume. They have asked this one, what will be this, right? Inspiratory capacity over here is 3380, and the tidal volume they have given is 460, right? The EC is given 1060, but this is unnecessary information. Respiratory is again unnecessary information, right? You're already given me the answers. Very good. Roy, Mohammad Saeed, Shivanshu, again Shivanshu, Sahil, very good, very good. So we have to just minus subtract the tidal volume from the 3380 minus 460. right? This is going to be 2920. That is going to be the option C. You guys have already given me the answers, so yes, definitely this is all from my side. The last message from my side for this month: the positive thinker sees the invisible, feels the intangible, and achieve the impossible. So think positively, because anyhow, thinking negatively that nothing will happen right now and how I'm going to cover up the portion for the exams in such amount of time. So always I tell you that convert your worry time into the study time, right? So whatever time is left, do the best. Whatever positive things you can think about, that okay, even if you wake up late, you can have some amount of time which is left in your hand. You can work throughout it, right? And happy Raksha Bandhan to all of you, not from my side, from your sister's side, right? So thank you all. I have my own brother which is not going to send me a gift this time also, I guess. So yes, so thank you all and enjoy your holidays and think positive, stay blessed and take care of yourself. Bye bye, good night.